one. If through the work we do over the next 5 or 6 weeks, I get back to a plan of 55.4 million with a golden quarter, and we've got confidence that those plans are green, and a reprofiling will be appropriate. What I don't want to do is to show the organisation as having balanced out turning month 1 and month 2 with £8 billion of risk park in February and March, and then that bite us as it has done other organisations historically. So it's a reflection of where we are now because of the risk we're carrying with the lack of the savings plan. And the savings plan is robust, and I think to Andrew's point, I will still put a line on the graph which says these are the savings we've got now and how they're profiled. Of course, they're not 55.4 million. I would be technically manipulating the position, which is difficult for me to justify for the board, albeit I'm happy to have further conversations about why that rationale is done. Maybe a number of other organisations have done that and had very challenging interviews from the scrutinies. So it's profile versus budget. And so the last thing, Chair, I should say is some of the operational budgets are not phased in 12. So we do have sophistication with energy, we do have sophistication on rates, we do make prepayments through the accounting systems to make sure that we spend profile is managed technically. And I'd like to be doing less of that and more of the value add in terms of different partner work, but that's determined development.
So Jean, do you want to come back on that? Because this is about not lulling the organisation into a false sense of security when we don't have anything like 55.4 savings funds identified.
I don't sound really draconian then, but to me it's the opposite. We're doing this, you are trying to profile the risk or present the risk to everyone. But they should understand what that risk is like and take the responsibility to deliver that month on month. So whilst we're using those, for me, you know, you're wrapping a blanket round and giving them a nice clutch and saying, I'm going to show you what the risk is, but we'll do it this way so that hopefully you look at that and then do some work to get us in the right position. I don't think we should be doing that. So for me, it's a completely shift in the culture that we're doing. You're far more coaching than I am.
Can I lift the blanket for the board? Totally respect you. What you may not see, which others do see, is in the recovery and sustainability boards in particular. That is less cushy. Abby chairs those on behalf of the organisation, and it's fair to say yes, the meeting was very instructive, very direct, and the clarity of the accountability on the delegate budget holders, whether they're the people in this room or the service group directors, it's absolutely on the table. So whilst it isn't executed through the route you've just described, Jean, the accountability, the ownership, and the allocation, the delegation process is very much in the forefront of mind. And since yesterday's meeting, I've received a couple of emails from service group directors offering different perspectives on what the solutions could be. So I detected a bit of a change. I've discussed this with you earlier. So
Just
you may have seen some of them. And I think we need to wrap that into a conversation with the executive on Monday to look at that. But I'm more than happy to have a session with members as well, because it's a really good.
Yeah, thank you. And thank you for the comments. And we share your concern and apologies that we are not yet in a position where we can give you assurance about the savings profile. We are absolutely on it and completely agree with you, Pat. We are consolidate because there are a number that are separate to do with workforce. They need team's going to bring them together under one kind of governance, because whether you're looking at it from a reducing sickness absence in some of the key areas, whether it's a staff a variable pay, there's a bundle around workforce that we need to drive from a workforce point of view. There's procurement, there's medicines. So we agree with that. The thing about the service sustainability is we do need to keep those programmes running that are about actually changing the way we deliver services. Because remember, we've got to do 4% next year and 3% the year after. And what we need to avoid is that we're going at the what I'll call the tactical savings year on year, because we will run out of those. And what we need is the service transformation changes coming through. So we have to balance both of those things, and it's the time horizons over the next 3 years that we've got to keep in mind. But absolutely agree. What we need is much greater confidence around the traction on the things. I was disappointed with month 1. I'm afraid month 2 probably will reflect that we haven't seen the grip and the action, and we'll need to reflect on that as a leadership team about why that message hasn't got through, because I think reflection from Liz's overview around the nursing, the profile, we should be, we broadly know where the benchmark should be for variable pay. We've squashed down agency and banks just gone through and yet we've in areas where we've got over-establishment as well. So there is a cultural shift that we need to achieve, which is going to be difficult out there. We've got services that are used to having above workforce in the workforce, above their call. And that's what we're seeing playing through. And we are prepared to give the direction around some of that. That will be noisy in bits of the system because we are changing the culture. And things like readiness through which we would bring in a registered mental health nurse for somebody overnight who's going to be sleeping. We've got to change some of those behaviours. You might understand why you'd want to do that, but actually do you absolutely need it? I have already seen the biggest service group's response this morning around no bank anymore. So that has been switched off as of today. That's the behaviour we need to see everywhere else. In terms of the individual service groups, some are asking for more help to get there. Actually, Morriston, they've got a pipeline. They were going to come back. They've got a planning session next week. They will get the plan back in. I had more confidence that they had line of sight to things they want to deliver. I think there are different conversations with the other service groups, and we've talked about we might need to meet with them service group by service group in terms of where they've got to. But in a sense, what we're giving executive cover for, and the board is giving us cover for, my guess is that we need to take those and push those difficult conversations around culturally you need to change what it feels like. And the responsibility you have to manage within your budget. You can't fill vacancy gaps if you've not got the budget for those vacancies because you've overspent, because you haven't brought down, and it's taking the responsibility for all of it. So again, we're going to be holding very hard, and actually it was a recommendation from the service group that we look to a different way of all vacancy, not just clinical in one place and admin and clerical in another, looking at a different way of managing all vacancies, which is you basically can't fill a vacancy if you haven't got your savings programme, and you need to right size and redeploy. And if we need to retrain staff because we've got more in this area and less in another, we've got to think about how do we redeploy and retrain. And that's what we're working through. And so the suggestion of enabling us to have a deeper dive on that with all of the exec leads, I think we've got a suggested date for that, where there's something else already happening, and we'll get that firmed up. And that would be really welcome, Jan. Thank you.
Thank you. And it is as well, isn't it, in the cultural change, there's less discretion really on some of these things because we have to drive and get that understood, isn't it? Really, the less discretion. Can I just ask before we move on, where are we with Welsh Government? I mean, Abby sent the letter in as accountable officer after the last. Where are we with that?
That's a good question. So we had the JET meeting, and we haven't had the formal correspondence from the JET meeting either. Actually, that's a good reminder. Yeah. So the expectation was that there was going to be a further conversation specifically about the plan taking place, but actually it hasn't come into the diary. So I have got a regular catch up with Welsh Government tomorrow, and I will check in with where we are on that. What I do know, Darren, is that you've worked very hard and we finally got the sign off. Colleagues will be aware that we needed Welsh Government, not Welsh Government, the NHS Executive Finance and Delivery Unit signing off the specification for the external support. We've now got that. Darren's progressing through the appropriate procurement process. We've got a date for the panel to interview, and we've got a timeline of when we would bring that support on board, and that will really help us. And I think the message we've been giving as part of development spec, we don't want an analysis of what we probably already know. What we need is that how do you get the implementation and delivery of the things that we need to execute. And of course, there are other opportunities, all the things around benchmarking, all the learning we can take from other places. Darren's doing a lot of that already. A number of us are talking about other places that have got similar sorts of sense of scale and what are they doing that's different to us. And obviously fresh pair of eyes with Tina and Liz coming in, which is really helpful too. So so I will update the board with a note, Jan, once I've heard back from Welsh Government.
Because that would be helpful, because we were at this point last year where the second iteration and we didn't conclude till September when the fourth iteration had gone in. So we would like to try and move on and actually get some agreement with them before we go into the second half of the year. Are there any more comments or questions or comments before we try and pull all this? Oh, Jean, you'll come back.
I just wanted to say that conversations that I've had with Liz and with Tina, to me, they've absolutely got to grips with this, with part of the problems. And that gives me comfort that they are taking action and have plans to take action. So thank you both for that.
So shall I try and summarise then where we are? So, I mean, obviously, as a whole board, we acknowledge our disappointment with the end of month one position. It's not where any of us would want to be, executive or independent members. So we have a collective disappointment in respect of this and a collective focus based on the advice from Performance and Finance Committee that we really now have to focus, first order issue, delivery of the 55.4 million savings target. We can't contemplate anything further. We know that has got to be our focus because, you know, we are all in this together as a whole. And also picking up on performance and finance, what we need to do now is, you know, a shorter number of areas to focus on. Do that with, you know, meaningful, sort of constant leadership from the executives, working with all colleagues across the organisation at whatever level of budget management they have, because everybody has to accept the responsibility, as we were saying. Yeah. So a shorter list of these themes with that more focused and forensic leadership, and then the one day in July where Performance and Finance Committee, with whatever other board members want to join in on this, does that deep dive into that shorter list of schemes to see how we can really major and focus the efforts on. And of course, we're looking for great things now from Tina and after that comment, but and then of course we do know that, you know, the directorates and the budget holders, the service groups, I do think now everybody understands the seriousness of this, and you know, and I think everybody is thinking about how they can contribute to this as part of, not just for their own budgets, but collectively, because I think everybody's in that position, in that space. So we can take some positive assurance, can't we, as you said, Pat? We will be coming back to our performance assurance framework, which is another really good piece of work. We do have external advisors, you know, on not too far away on the horizon, and they will also come in and give us added expertise and assistance. So is that where we are, do we think? And we are going to obviously go back to our government to see if we can secure an outcome and outturn the bid down what the expectation is for 25-26 without having to wait. If that's not really helpful. Have I covered everything?
I think Abby talked about the cultural change aspect.
Yeah.
It is critical, you know, making sure the right people are engaging fully in those work streams, and you know, it's going to be, that's going to be a challenge.
Yeah. And that's part of the big cultural change piece, isn't it? Yeah. With all the transformational program work we have underway. Thank you very much. So, okay. So we move then on to 4.5, which is our integrated performance report. And as I said earlier, this is still under construction and refinement. So Darren, I know you can introduce it, will you, and then hand over to Executive Director Collins. Is that correct?
Yes, thank you, Chair, that's correct. So what I'm going to do is explain the changes in the structured report and our ambition, and then I'll be leaving with colleagues to actually talk about performance in the report. As you said, we're on a bit of a journey. There are currently 3 separate elements to the report. Ultimately, there will be one, but we don't want to lose the governance of having a really clear escalation report, which the board has asked for relatively recently. So there's a document in the pack which shows every area of escalation from target intervention down to service of concern, which to maintain the governance through. The second part then is what looks like a presentation pack, but that isn't the new performance report, which at its early part of the structure that gives you the performance in numerical terms against target intervention, And from then on, it's structured based on our 5 strategic objectives as a board. So there's now alignment between the performance areas and strategic objectives of the board. When I hand over shortly, my colleagues will take us through each of those individual sections, and we've rehearsed it this morning, so I'm sure it's going to be fine. The thing perhaps to add as well is that where either board or committee asks for further detail, this flexibility of reporting allows us to drop in an extra page or 2 on that. So in this part today, it's going to be optimized page, there's a theme visualization page, and once assurance is gained, we'll take those back out and they will become normal reporting. It gives us a chance to make this a bit more agile. And in the spirit of becoming more digitally enabled, but not quite there yet, there are links in the document should colleagues wish to click on to see more of the UEC dashboard, the talent prevention dashboard, or others. Those links are live on the document. If colleagues can't access those, please email me. We'll make sure we get them. I think it's fair to say there's more to do around probably measures outside of the core acute sector. We have got some population health measures. We have got some primary and community health measures. We're working to extend those. Ultimately, this journey is one to get us to a place where we'll have a spine of core health board information that will be replicated through the service groups to inform the performance review process, which we'll talk about in the accountability framework. And that will be a much more live digital discussion, but I will produce a document for the record, and what the document is draw from the digital backdrop. So this is the start of the journey. It's a bit manual at the moment. I'm very grateful to my team for doing this, but we will get there, and I'm getting support from colleagues in other directorates to do so. The other thing we've tried to do, and I will stop and then I'll hand over, is in the core summary sections of each part of the performance report, we've designated whether the performance areas are in target prevention or through ministerial delivery as well. And that maps through in terms of the circles we've used in the key. Final thing I'll say then is there is an enabling actions section, the Cabinet Secretary enabling action section. That's the bit where I think we need to do more work. There's a lot in there today just to show the scale of what we're doing across the 35 enabling actions. And Chief Executive has asked me and the team to look at how we align those with the Ministerial Advisory Group responses and the Welsh Government response to the Ministerial Advisory Group. So we're going to do a matrix there as well, which you'll see as this evolves. So that's what we're trying to do. I hope it's a step in. I'm happy to take critique, but what I'll do now is hand over to Deb to start us off on the run through the core performance metrics.
Thanks, Chair. Thanks, Darren. Okay, so as Darren alluded to, there's a more detailed escalation report after the slides. I'm just going to talk you through the headline performance figures in the slides as they stand, and further detail on all of the measures that you see in the first couple of pages on the tables are within the slide pack as well if we need those. So just starting from the top, so cancer, we've reported our March performance. We haven't reported April yet, and that did recover from a really poor January, and we achieved 62%. We had hoped for 65%, but at the moment that was a bit shy of that one. But as you'll be aware that the quarterly refresh of that will see an improvement. So I'm hoping that we'll get to 65% when that refresh takes place. Urgent and emergency care, still an area that is more red than we would like to see at the moment, but there is an amber in there, and that amber hopefully will be green when we report in May as well. So ambulance handovers, there is some improvement in that, even though it is stubbornly consistent where we are at the moment. We are starting to see the improvement in those figures. 12-hour waits for ED, 30, you see the target is 7%, 13% waited more than 12 hours in April. That reduced to 11% in May, so May was a better performance for us. And as we know, the work that we're going to be doing with the emergency department and Flow in Morriston starting next week will hopefully give us a far bigger improvement as we go through the rest of the month. ED assessments, so that was up to 83% from 79%. Even though the target is 95% on that one, we are probably the best performer in Wales on that particular measure, which is positive for us in terms of we do have early eyes on the patients when they arrive. The good news in the UEC space, is, as Pat alluded to earlier, Chair, is the clinically optimised position. So it is amber with 211 clinically optimised patients reported in April. At the moment, that's reduced to 191 for May. So there's a couple of days left in May that it could go pitong, but as it stands, that will see a 32% improvement from our starting position of 283. So that's a huge difference in where we're trying to go in that space. And the board will know our target for the end of March 26 is to reduce that down to 100 as a minimum. If we can improve on that, that will give us even bigger benefit. And there's more, a bit more information on slide 14 of the pack on clinically optimised patients, and the table on that slide gives you the number of patients waiting in each of the reasons for the delay category. And again, you can see the improvement across those highest numbers as we've gone through recent months. Again, so a good improvement on that one. Hospital-acquired infections, Liz and Richard will talk us through that after I finish, so I won't go on to that one. And similarly, finance and strategy, there's a lot more detail in the report that I'm not going to go into here. CAMS and plan cares, we know they've reduced from targeted intervention into enhanced monitoring. CAMS is showing for this report at 75%, but we are confident that we'll recover back up to the target level and some significant improvement in consistency there. Plan care, we know that's a good news story for us. Just to give us a little bit more good news, we are now the only health board to consistently deliver the 104-week target in April. So even though Hywel Dda did deliver it at year end, they did not deliver it in April. We did, and we will continue to deliver for May, and June is in the bag for us as well at the moment. There does look to be a blip in July, and we are still waiting for some additional confirmation from Welsh Government on funding on that one to make sure we can eat into the backlog that's sitting there in July at the moment. The board will be aware that we've also had someone else from the Cabinet Secretary on additional work that they're asking health boards to do to reduce overall waiting list volumes. Just for the minute, our share of that is just shy of 25,000 additional outpatient appointments that we will be able to put into the system this financial year. We're just waiting for the contracts to be signed on that because the most significant volume of that, so just over 20,000, is via an insourcing company, which is going to be centrally procured through Welsh Government. Health boards do have to own those contracts though, so it's really important the board is cited on those contracts for us, but they're being set up through Welsh Government auspices. I'm on the board for the review of those contracts, so we'll be closely linked into that one. Cataracts, there's 20,000 additional cataracts pathways going into the system this year. Our cut of that is about just over 2,000 cataracts, so a significant additional capacity for our population this year, which will hopefully reduce our first outpatient waits down to 16 weeks, which will be brilliant for everybody who's waiting for those, and then we'll reduce our overall pathway lengths as well. The one blip in the plan care world for us is endoscopy, so board will be aware that the us not achieving the 8 weeks within that one. There are additional plans in place by Welsh Government to put more capacity into diagnostics this year, and endoscopy is going to be a big proportion of that. We're just waiting for the confirmation of what that looks like. We have submitted our plan. It is likely to be approved. I just haven't had the confirmation yet, and that hopefully will give us the capacity to deliver 8 weeks this financial year, which at the moment it was looking at June 26 without the additional help there, so that would be good. Other performance issues just quickly that are not in the escalation bit. So stroke, another board's been interested on the stroke pathway. Flow or lack of flow we know has a significant impact on our the quality of our stroke pathway, particularly on the admission to the stroke ward and treatment then onward transfer from the stroke ward into stroke rehab, which is in Leeds Port Talbot. So the work we're doing on flow will give us benefits in that one. But alongside that, we've also been looking at the access for CT scan, which obviously is a prime diagnostic for confirming stroke. Last week, 8 of our patients who arrived by ambulance, all of those went directly to the stroke scanner, the CT scanner, which is what the pathway we've trying to be put to take those ED issues out of the system. So that was really positive. The downside of that, however, that only 2 of the 8 had the scan within 20 minutes, which is the new target. So within the report, you'll see an hour quoted at the target. The new target is 20 minutes to CT scan. That said, all of them had the scan within 50 minutes. So all were within the hour. So there's more work to do there, but it's those little wins with the CT scanner access to make sure we get that as quickly as possible. But again, some improvement in that one. Theatre efficiency was the other one I wanted to pick up. So that's new in the report, as you've seen. Point of clarity on that. So on page 226 and 227, for those of you looking through the pack. The first slide, so 226, there's a graph at the bottom right-hand corner of that slide shows percentage theatre cancellations, which is sitting around 32% for April. But there's a narrative at the bottom of that slide but on the day cancellations at 8%. It sounds as if there's an error there, but it's not. So of the overall cancellations, 32% were cancelled on the day. The total number of scheduled operations, 8%. Were cancelled on the day. So both are correct, but when you look at it, you think, well, they can't both be correct, but it's just the narrative around that. But we'll work on that to make sure that we've got a bit more accuracy on there. The cancellation on the day numbers is accurate because they are cancelled on the day, we don't backfill them. On 227, however, the overall number of cancellations is a little bit misleading because it includes everything that gets cancelled, which includes things that are cancelled, for example, if a consultant is going on annual leave. Well, that's a planned cancellation, if you like, and most of those theatre slots are backfilled with different surgeons, but it's a very pure way of looking at it rather than the impact of it. So I'll Megan and the team to make sure we've got a bit more intelligence on that one. NDD, we also talked about earlier on. We are expecting additional funding to come through into the NDD space as it did last year at the moment. That's part of the Cabinet Secretary's announcement. It's the number 6 one. So I think diagnostics is number 4. So NDD is coming soon, but we don't know what that looks like at the moment. But there will be some additional funding to come through. The issue with that is it's not sustainable for us. So we've just got to work with what we've got in that space. And then lastly for me, enabling actions Darren touched on. We've been asked by Welsh Government and NHS Exec to work with the national team on and put in some clear rationale behind how we calculate some of the quantifiable enabling actions measures in that. They issued the narrative without really thinking about, okay, how do we ensure consistency? And measures like theatre utilisation is really important to get it right so all health boards are reported in the same way. So they've asked us to link in with on that, which is positive news for us. That's it from me, Chair, and I think I'm handing over to Jill, who's on Teams for us.
Can we take
Yeah.
questions back in each section,
Okay.
because you've covered so much.
I'm a bit of a torpedo, as we know.
Just that, any questions or comments for Nicola?
Thank you, Chair. Thank you, Deb, for that really comprehensive report. It may have already been in there, perhaps I've slightly missed it. Just going on the cancer, another 265 patients waiting in excess of 63 days. Do we have the data of how long over those days they are waiting as patients?
I don't have it with me, but I can certainly provide that to you outside. And we can see if that needs to be included. So we've got the total backlog, but yeah, you can see how long the waiting will be important when looking at that.
And are we communicating with the patients?
Yes.
That are waiting there. Thank you.
Okay.
Any other questions? Keith?
Also, thank you very much for the report and for taking us through it so clearly. I had a question about the slides near the beginning of the pack on delivery against targeted intervention, enhanced monitoring criteria. So the first one in this slide on escalation area level 3 is CAMS. But looking at the criteria to achieve, those look like the ones for adult mental health rather than the ones for CAMS. So if you look at so CAMS has 4 criteria to achieve later in the report. What I think is in this particular slide, looking at what the criteria to achieve are, they look like the adult mental health ones rather than the CAMS ones.
So as part of targeted intervention, they were the measures they wanted us to achieve to come out of targeted intervention. So they're not the full range of the CAMS measures as you'd see later on in the report.
Okay, so the criteria to achieve look like the data for adults, but you're saying that those ones also apply to CAMS.
For this measure.
They're the ones that have been achieved, can go down to level 2, leaving the other ones left.
Yeah.
Okay, got it, thank you.
Yeah.
Rina?
Yeah, thanks, Deb. I mean, the concern I have is that within this, there are some things saying actions. I'll give you one example that I picked up, is that we're going to have senior decision makers at the front door of A&E. Now, again, we've been discussing that since we had the strike of the junior doctors last year. And yet, it seems to have taken a year probably to be in action to a rota starting in June. So I'm a little bit concerned that some of these things that we decide they are, you know, good, this is the way we should go, but it just seems to take us a long time to put things into place. And that's where I'm a little bit worried about things like the things that Pat was talking about in terms of that we're not seeing any traction in terms of improved performance. And yet we've been not seeing anything for years. Have we got our priorities in the right place? I mean, you could say, okay, we haven't got enough money to add into NDDs or whatever, or to improve the stroke beds or whatever's required in those areas that are stubbornly not moving. But I just think there are choices in that. And have we questioned whether we are taking the right choices? But I will say there's some really good information in it too.
And I'm particularly pleased about the work on the clinically optimised, because clearly if that does impact and does continue, it will impact on the ring fence beds for stroke and the neck of femur. It will impact, but it needs to, put it that way, because we've been sitting in quite a difficult position on some of these areas for some time.
Yeah, would you like to?
Yeah, I'll come back on that one. It's a fair challenge, to be fair. I've spoken to Morrison Service Group on a number of occasions of when the new rota is coming in. To be fair to them, it's not something that's been in their gift, so it's not been a choice issue. It's been a case of we needed to recruit more staff into that rota to get it filled, and then to work with the consultants who need to work differently to get them to take on the new job plan. So it definitely has taken longer than we wanted, Gina. It should have been in place originally in February 24. So it is a long time coming, but I am really pleased to say it will be in June, and we'll see the benefits from that. We've still got more to do with recruitment of substantive staff to fill the rotas. I'm hoping if we can see the improvement that we anticipate with the plans we've got in place, that will attract more staff to come and work in this service as well.
Any other? Jean, would you like to come in?
Thanks, Deb. I really like the way the report is evolving, because I think it gives us far more clarity around what targeted intervention looks like, around what other figures look like. But one, though it doesn't take much to confuse me, but if we look at the delivery against the targeted intervention for UEC, and we look at the figures that you provide, which is continuous reduction of ambulance handovers, 629, against the target of the handover over an hour of at least 11% in 3 consecutive months. So how can I correlate the 11% against the 629 that you've quoted? And then when you read that, those whole 4 elements that you give narrative to under the UEC, they're confusing me.
That's a fair point, Jean. We'll get that included as well. The link to the dashboard will give the different information on the percentage, but you're right, is that consistency.
Thank you.
And you're not easily confused. The reason I put that information in about theatre utilisation, because I knew you'd pick it up.
Thank you. I've got Nuria and then Pat. Nuria, please come in.
Thank you for that report. I think for me, it's following up from Rena's comments. We had a recent Audit Wales report on unscheduled care relating to flow, and it highlighted poor stroke performance as a consequence of routinely breaching the ring fence of stroke beds to manage ED pressures in Morriston. So it's that kind of, prioritisation and assurances that we can get on top of that situation. And you have explained some of the work that you're doing in that respect. But I also have concerns about our follow-up outpatients performance. We seem to be prioritising neo-OPs on an RTT pathway where there is a huge pressure to deliver over follow-up. So our work can assure us that from the perspective of clinical need, we're getting our priorities right, which I think was what Rena was alluding to.
Yeah, I'll come back on that. If I take the last one first, so we're definitely not ignoring the not book waiting list, and that's a big focus for us going forward. Some of the additional work that we've got to, we can put bids into Welsh Government on for this year. We are going to include the reviews of the follow-up not booked waiting list. The main issue with that waiting list is that most of those patients should not be there, not that they are waiting for an urgent follow-up. We've just got to work through that to make sure they are discharged first or put onto a patient-initiated follow-up secondly, and then we know which of those patients need to come back. So we've picked that work up. Last week, I had my first meeting of the clinical committee that I put in place to manage the work of the clinical implementation network, which is something else the Welsh Government have put in place that we're waiting for reports on, and we picked up that piece of work in that committee. So the consultants are very well aware of the work we need to do this year on that one. So I'm anticipating we'll see those numbers coming down through this financial year. With regards to the stroke ward, it is a really important issue, but it's not solely down to moving patients out of ED onto the stroke ward. It is also the blockage underneath Port Talbot Hospital for the clinically optimised patients who've been there that we can't move our acute strokes into the rehab beds, which means they're spending far too much time on the acute stroke ward, which means we can't get through. We only have 18 designated stroke beds, so we need those to turn over relatively quickly for us to work. I've looked at a piece of work today that Cardiff and Vale have in place, and their admission to the stroke ward is far better than ours. and I questioned how many stroke beds they've got. They also only have 18 acute stroke beds. So it's how does the system work to make sure that we can get the patients through the system, diagnosed quickly onto the stroke ward, and then out of the acute stroke wards, either discharged home or into the rehab spaces as well. So it is a full pathway piece of work for us that we'll see the improvements on.
So Nuria, you showed on that, and we'll have some feedback on that work, I'm sure. Thank you very much, Des, for a comprehensive update and answer questions as well.
Sorry, it's only a very quick one. Thanks, Shannon. Just for Nuria. So it's worth bearing in mind as well that the point a patient needs a CT scan at the front door is when somebody thinks they've had a stroke, not when they've had a stroke. And only about 1 in 5 people who present as query stroke have had a stroke. So as part of that challenge as well, not everybody who comes in with a label of has this person had a stroke, the majority won't have had a stroke. And so that challenge of getting that patient really quickly to the right bed if they need it is one of also then when the scan comes back and it shows they haven't had a stroke, is moving that patient onto a different destination that might reflect their need for care. So it's sometimes a point that gets lost, that the point where the request for a CT comes in is prior to having definitive diagnosis.
Sorry, you wanted to come in.
It was only a general comment really that the report it's an very much improved approach. It's very comprehensive and it's allowing an ongoing review of the areas under escalation, either under escalation by Welsh Government or areas of our own concern. And it's allowing more detail to come through, and that an intervention focus is really useful, particularly for the areas like access to stroke beds or NGD, which we might not pick up in other ways. And it's how we use that I think is going to be important to give us that. But it is, I think it's a big step forward.
Darren, who's next?
Your colleague on screen, Jill, who's fresh back from France.
Thank you. Good afternoon, board. Can you all hear me? Great, thank you. So I'm beginning the section 2, which is the summary of the performance against the Health Board's strategic objectives. As you know, we've got our refreshed strategic objectives allied to a Healthier Wales. And the first of these is that the people of Swansea Bay live healthier, equitable and more equal and prosperous lives. So the measures, I'm grateful to Darren's team for helping bring these together. They centre around immunisations, smoking cessation and screening. The childhood immunisations, the percentage of children up to date with their scheduled vaccinations by the age of 5 is on target. The percentage of children receiving the human papillomavirus vaccination by the age of 15 is approaching 90%, but not where we would like to be. We've got 5% really improvement we need to make there, if not more. But that is the vaccine that protects against cervical cancer. And also for males, there are cancers as well that are protected, such as head and neck. So for the influenza and COVID vaccinations, the influenza vaccine for adults 65 years and over fell short by 6% at least. We are having an early start. The team is already beginning to look at our interactions with our population that has the influenza vaccine. Both those over 65 and other risk groups too. The COVID vaccination for this spring booster has been particularly disappointing. There is definitely, we feel, COVID fatigue out there, that people are feeling, do we really need this vaccine still? So there's some insight work that we need to follow up on. We need to design our education campaigns carefully with the Vaccine Preventable Diseases programme at Public Health Wales NHS Trust. And we need to make sure that people appreciate that this virus can still cause hospitalisations and long COVID. I think perhaps the fact that the spring was quite sunny, warm, people were not perhaps having as many bugs and viruses that people did feel a little bit complacent perhaps. So that there's a job of work to do there. Smoking cessation, we are awaiting data for these measures, but we will be measuring the percentage of adult smokers who make a quit attempt and also the percentage who are carbon monoxide validated as a quit at 4 weeks. We've also got some screening measures down there, which the first of which will be showing us what our colonoscopy procedure rates within 4 weeks are, which is very important as a follow-up to the bowel screening. And also looking at the newborn hearing screening programme and the newborn blood spot screening, which is important for detecting important genetic conditions which need immediate attention. So conditions such as phenylketonuria, where a specialised diet is required very early on to avoid harm to the child. So if we go, there is also a slide in more depth on the immunisations. You'll see that we are fairly close to the Welsh average, or above or hovering below for most of the measures. But we are very disappointed about our COVID vaccination uptake, and we are also making efforts to improve our MMR uptake. As you know, there was real difficulties in our area following a lot of vaccine scepticism over the MMR in particular, and that does seem to persist, although the levels are much higher than they were at one stage. So I'll pause there, and Liz is next on the agenda, but if there's any questions.
Anything for Jill? No, should we hand over to Liz then?
Yeah, changing around then.
All right, okay.
We go. So I'll start us off. It'll be me, then Liz, then me, then Liz, I think. So we're picking up HCI. So for the benefits of committee members, I'm on slide number 19. If you've got numbers on your slides, or slide number 18 if you've got the PDF. I'm sorry, I can't help you if you've downloaded the entire bundle. It'll be there somewhere, but it's the infection prevention control slide. So what that slide shows us is metrics against 4 infections: Clostridium difficile, which, as you know, is an organism that causes diarrhea; Staph aureus bacteremia, Staph aureus being an organism that lives in the skin; E. coli, which is an organism that tends to live in the urinary tract; and Klebsiella, which tends to live in the GI tract. And the way that these infections manifest them is typically according to where the site they're normally found. Board members will see that the y-axes on all of these are all slightly different, and so your interpretation of the absolute numbers is slightly different. And you'll notice that, broadly speaking, the number of cases of E. coli and of Staph aureus are relatively stable. For Staph aureus, we have come down a bit since November. And for E. coli, we've gone up a little bit in the early part of the year and down, but numbers are very small, and there are good plans against all of these in terms of addressing the incidence of hospital onset cases of Klebsiella tend to happen in either very vulnerable patients, so intensive care, the burns unit, or in patients who typically have got sepsis related to the gallbladder. And again, numbers of Klebsiella, we have been well below the target level, but we're around that level or slightly below. The area that we picked up earlier, which is much more concern of us, is our ongoing high rates of Clostridium difficile, which fall into 2 categories, I think. The first is the number of overall HCI cases, where historically Swansea had a much higher rate than the rest of Wales, and probably represented the fact that our local population was colonised, or at least had a higher incidence of C. diff in the community related to contact with healthcare or prescription of antibiotics. And while we have picked up some of those cases when people came into hospital, the one thing that we hadn't seen was transmission within the hospital setting. So people might have come in and presented with C. diff and be diagnosed with it. But we tended not to have transmission events where that was passed from one patient to another on a hospital ward. And unfortunately, we have seen that recently with several transmission events. I think the number of cases, Liz, around, is that right?
Yes, it's month 11.
In terms of the actions, you'll see that the footnotes details, we gold oversight, the quality improvement plans, the improvement in our antimicrobial stewardship will all contribute to that. But we're very aware that some of the issues that Dan talked about earlier, the biggest contributor to this is overcrowding on our wards, being above capacity, people waiting in ED for a lengthy period of time. And obviously when we're over capacity, our ability to isolate people who start to exhibit symptoms is much more limited. So linked to what Deb was saying about unscheduled care, linked to stroke, some of the initiatives that we're about to be starting off around unscheduled care, which will see us improve flow in the system, we'll anticipate will be significant contributors to reducing our levels of clostridium difficile as well. Liz, have I forgotten anything?
No, and I don't think we can underestimate that either. And we know that UK-wide research has shown C. diff increase, which is across the country, has been linked to overcrowding in hospitals or hospitals that are full, and us having to care for patients in environments that are less than optimal. So, you know, the work that we are doing around flow through the hospital will definitely impact on this, as well as all the other things that we're doing. And I know that Angela has led on this on behalf of Richard, and the gold meetings have been led by her. But for the future, I think it'll be something that I'm going to pick up through quality and safety.
So we're going to go from the ACAI section through to patient experience and visit.
We are, and again, I'm pleased to take complaints and patient experience as part of my portfolio. I'm just getting to know the team, and we're just looking at processes. It's very different processes in Wales than I'm used to in NHS England. However, I think that we've got a good team, good foundations. We're going to have some time out together to look at the systems and processes. And I've also committed to the service groups to working with them so we can be more efficient in our processes around answering and responding to complaints. We do have a low rate of return. However, it does take far too long for us to respond. And we know that we want to listen, hear and respond to our patients and the population in a very timely way. There's just something I wanted to pull out, which I think we should be cognizant of as a board, which is a real positive. So there's a new patient experience framework in Wales, and we've been piloting that and taking part in its production. It replaces the listening and learning framework, and there's a whole new suite of questions for patients. It's mostly done post-discharge. It's done on a national basis. Our teams have worked really hard to ensure that that is available, that people know about it, that we do encourage people to tell us about their experience. We're the second highest in Wales for response rates, which is great. It's a new survey. We are the highest, second highest in Wales. We will be the highest. But we've had feedback from over 600 areas within the health board, and we've had a huge amount of response from ED, Anne-Louise, and we've talked about ED and the things that people are telling us from there, and that has led to some changes in provision of food and drinks, and we could respond quickly because we see the information quickly. So the information is uploaded onto the Beacon dashboard on an all Wales basis, but our teams are getting regular updates of what patients are saying about them and the services they provide, so it could be much more timely in response. So that was really what I wanted to highlight on patient experience, but I think it's a real step forward for us.
Then finally over the page on the next one, which is the serious incidents and risks. And just the one issue to pull out for the board, I think, on this one, and that's the never event that's on that chart for April 2025. That is a never event related to dermatology, where a patient presented with multiple skin lesions with a plan for one of them to be removed, and the wrong one was removed. It's a low harm incident in the sense that a lesion was removed, but it didn't mean the patient had to come back. And it's just to let board know at the minute as things stand, it's likely that we'll have two NEBRA events that will come through from May. One related to the wrong site anaesthesia, and the second, which will be graded as severe harm, and the second, which will be graded as low harm, which may be reviewed, which was a retained guide wire following insertion of an intra and venous catheter. But those will come through, they're being worked through the system at the minute. I'll leave it there. So that's the quote. Before we hand over to Darren, should we put your reports there, Jan, for questions and reports?
Thank you both. Steve, over to you.
Yes, hospital onset and the definition of hospital onset, because we used to measure, I think, all infections, including those from the community. The ministerial targets specified hospital onset. So are we omitting community acquired infections, i.e. typically in care homes? And if we're omitting them, have we lost sight of, from a prevention point of view, we should be keeping an eye on them as well. So
So the nomenclature has changed from healthcare, from hospital acquired to healthcare acquired or healthcare associated. For the purposes of the enhanced monitoring, it's particularly hospital acquired, isn't it?
Yeah.
So but the rest is still being included.
Yeah.
but in this,
The graphs have got both, I think. So yeah, there's two bars.
Yes,
They've got both.
okay, that's, thank you.
Few more to talk, Jan, but we're conscious of time. So
And can I just mention very briefly, one thing that's missing, and conscious that this is with involving this, is data on mortality and mortality included in the back.
We are going to break at the end of this item. So, yeah.
because we've got Gareth in the digital section, then Tina, then myself. You'll proceed in brief style, Jan, would that be helpful? So Gareth.
People will have read there,
Yeah.
will have read through everything. So, and then we will have that 20-minute break after that. Will we turn it to Gareth?
Gareth.
Yeah, so as we've outlined in that strategy, we see digital as an enabler, achieving across all of the objectives and the influence and improvement we can help support deliver that. So what we've outlined in our section is the key deliverables for this year and the movement towards the delivery of the strategy in the future. I think a few key things to highlight is that the maternity case for the digital solution to go into maternity, that was submitted at the end of March as per the Welsh Government guidelines. We're still waiting to hear back from the status of that, although we are now starting to get clarification questions come through. However, that doesn't mean the work on the project has started, so the planning and the project work and the initiation work around getting that off the ground so we can implement by the end of March is ongoing. From Swansea Bay Patient Portal and the supporting of the National App, we're still leading the way across Wales. We are the organisation that has a patient portal, and we know we're using that to support a hybrid mail initiative to drive efficiencies through reduction of postage. The removal of the blockers we had of the use of NHS login over the last few months has meant that the adoption of the Swansea Bay Patient Portal has increased significantly. So we are now up to 12,000 patients who have signed up, and over 1,500 who have signed up in April, which is a good sign. And we've got comms campaigns, and we're at the festival today to promote the adoption of the Swansea Bay Patient App. We've got two significant replacement projects going on this financial year in LIMS and RISP, both in the diagnostics element. So LIMS is the pathology system and RISP is the radiology system. There's a significant amount of work going on there, working with the OGW and looking at options, particularly pathology, around working regionally together. So we've got a regional board for the implementation of things we've done. And we are also now starting to work on the delivery of the digital system within ophthalmology. Again, we've had direction from Welsh Government of adopting the Cardigan Vale solution, hosted solution. There's work ongoing related to that in terms of the planning. The other key point to focus on, which isn't about the delivery systems, but making sure our data is secure and accessible. Is there a money at the end of the financial year to add to replace our networks, and there's significant amount of work going on in the background now to start that network replacement, 2 pieces of work that have been completed this week. So we're making progress in terms of making sure that we're refreshing our networks to make sure we're about the security and the functionality that those networks can bring. That's always a stop talk.
Immediate questions or points for Gavin?
Just a point, in terms of the actions on the digital, it would be quite useful to have as part of that some kind of notion about progress on them. So are they in progress, complete? Just some kind of simple coding or something, colouring.
Yeah, thank you. Indicate that. It's really helpful. Take that action. Thank you. Tina?
Yes, thank you. There's 2 issues I want to draw to the board's attention. The first one being the appraisals, the ADR, where we've been consistently below the national target, which means that at least 25% of our staff haven't had that quality conversation with their manager about their performance, their objectives for this year, health and well-being, and their personal development. So I will request the support of the board in lowering our risk tolerance on this, because to me it's not acceptable that it's not having an appraisal with a line manager. I've only been in 4 weeks, but I'm taking a deep dive into this issue to find out what the barriers are to that higher completion rates. Is it the same people not having appraisals? Is it that they've got to make direct reports, etc.? So I'll take a report through reading to the August Watch Committee with my findings on that. That's the issue. The other issue, which is the wicked issue that we all talk about regularly here, is the sickness absence rate. And again, in my first 4 weeks here, I think there are 3 issues that we need to focus on, which I will lead on. One is that we need to make sure sickness absence is seen as a top priority. So every team meeting conversation we're having with our staff should start with the well-being and making sure people are aware of the support and the importance of that. The second part is about the proactive nature. So the majority of our sickness absence, so 35%, is related to what's called S10 mental health related absence. And yet when I've looked, we've have quite low levels of proactive stress risk assessments on a team and individual basis. So there are things that we can be doing to be more proactive in those areas. That's something I'll be taken forward. And the third aspect is around getting the basics right, making sure we're fully compliant with the policy. If you apply the policy, it works. Making sure the return to work in meetings, etc., the recording of that, regular check-ins, but also reminding colleagues of their personal responsibilities for their sickness absence and what proactive measures they're taking to make sure they're fit for work going forward. So happy to take any questions on either of those.
Any questions? We know that Workforce and Wellbeing Committee actually follows these things through. Thank you. Yes.
Just to add, there's a really good dashboard behind this which gives you with the distribution of many metrics. And so from a finance perspective, this isn't for completeness. We'll see replication of some of the charts I discussed earlier. I wasn't going to repeat that all the time, Chair, but just to say, out of the map, the revenue position here, we'll give a distribution and trend on variable pay. We'll pick up the FBP target as well through the year, depending on the interest, maybe something on savings and the profile we discussed really helpful to add to that. But we covered this in the last.
Well, I think we've had a really good run through this new integrated performance report. I think generally very well received and welcomed. And I think we've had a wider range of discussion against this agenda item than I can remember in a year. I don't have other colleagues as well. So really welcome. Yeah. And continue with the refinements. And it is really good piece. Yeah. So it does absolutely work well. So we support it, and we've taken a lot of assurance from the information we've had, the discussion we've had, and the actions we've agreed. Thank you all. Thank you all. Everybody was involved in putting this together. So now we're going to have a well-deserved 20 minutes. And then can you just do a bit of juxtaposition when we come back? Because Denise and Ken are here for item 6.6. So could we come back and we can move to that item, and then Debbie will then go back to dental services. Is that okay? So if we can come back then, 25 past. Just thinking. Yes. Croeso arbennig I Denise Trevor ac Edmund Nanma. Please, a very warm welcome back to the board. We're delighted to have you with us this afternoon for a further update. You join us at section 6.6 on our agenda. There are 3 items in this. This is going to give us a little where next in terms of the future focus. Raj is going to present his last Lower Command report to the board, and then we'll have an update from that. Is that okay? Thank you. Thank you. So Liz, over to you.
Thank you, Chair. It's really nice to meet you in person, Denise and Ken. I think that since I've been in the Health Board the last 8 weeks, obviously maternity has been a real key focus for me, and for the rest of the board, it's obvious that it is. And I've been asked to take on the role as exec lead for maternity services. It's something that I'm used to doing. It's something I've done in other organisations. But I do that with reverence and a huge sense of responsibility personally, but also the responsibility for the board feel for maternity services and the improvement journey that we're on. And we've all heard the feedback and discussed it at board. From the Llais report, from women and families, and through incidents and complaints that we have been investigating and reviewing. And that has been really difficult to hear. And I know that Abby said that, Jana said that, the whole board has said that. And we know that there are times when we've not listened with empathy and compassion. And the consequences, as Abby said this morning, can be devastating. And I know the board has apologised for that. So I want to talk about what's next and where we go. And I know we're all committed to using all feedback and lessons learned to continue to improve and to ensure that we always listen to patients, their families, and indeed to our staff when they are raising concerns. We want to fundamentally transform the way we hear and respond. This will help us to provide consistently safe care with compassion, and we're grateful to all of those who have and who will continue to help us to improve. Using the feedback from Llais, and when we receive the independent review, we will need to respond with openness and transparency. I also welcome, since I've been in post, understanding the All Wales MATNEO safety programme and the delivery plan, which will provide a framework for services across all of Wales, but we will need to evidence delivery of this as well. We can only do that through a very clear governance structure, and that's really what I want to focus on to take us forward. We will continue to work with our families and staff to embed the changes that we need to make, but we need to make sure that that's a continuous improvement process and that it's a sustainable improvement in care outcomes and experience. For this, we will establish a perinatal committee, which will meet on a monthly basis and have oversight and scrutiny of our improvement programme and outcomes, and will report through to quality and safety. I will chair that forum, but there will be terms of reference and a membership which we are currently working through. We intend to have that first meeting on the 5th of June. We need to be clear how we'll monitor safe care and performance, and this will help us to ensure high standards of clinical behaviour for our teams to work well together with the patient at the centre. We know that this will take effective leadership. We've made some strong leadership appointments in maternity. A director of maternity will help us hugely, but it is about the whole disciplinary team and all that are involved in that. We need to ensure that they're supported to improve and that they have the capacity to do so. Providing a detailed oversight of key outcome measures will help them to do this, to know how they're doing. We want to actively encourage the MATNEO Partnership Voices Partnership for all women and families to help us to improve and to encourage, I'm going to say co-production, and it is about real co-production. We've had a conversation about what that means this morning in another arena, but it has to be co-production for real sustainable improvement. And through this, what I've seen develop in other places, and I know will develop here, is a positive culture where we can demonstrate clearly with evidence examples of teamwork, professionalism, and listening to women and families, and where our staff feel supported and empowered. And this will deliver sustainable care, safe care. I suppose in summary, the commitment is to demonstrate openness, honesty and candour, and that we will listen and act on what we hear, that we will find and face the truth, learning from errors and failures in care, and promoting that culture of continuous improvement. I'm just stating that here for the future. There's a lot of work to do, and we are, as I say, establishing that committee, which will be a huge part of it.
Jean, do you want to say anything as the chair of Quality and Safety Committee as to how this committee that Liz will chair will feed in to?
Yeah. I'm obviously having meetings with Liz and some of the other senior execs about how we revise the way in which quality and safety not only monitors, but works through the evidence output from all of these committees, because we don't have visibility of that in any kind of simple form whatsoever. So we're doing a lot of work around understanding what the terms of reference for these groups look like, what will we measure, how frequently will we measure, and then what time frame will the results manifest themselves. So a lot of work to do in resetting that, but every one of the execs are absolutely on board to get that right.
Thank you. And we look forward to further details of it in the future. So Raj, we welcome you back again. And as I said earlier, I think this is your last Goal Command report to over to you.
Thank you, Chair. After all, I'll take the paper as read and noted. And just to give a bit of a background, in December 2023, the Health Board's maternity and neonatal services were placed by Welsh Government in enhanced monitoring. This was following an HIW visit in 2023, where areas of concerns were found. So Goal Command structure under myself as a senior responsible officer set up to take assurance that action has been taken. So the main focus of the group was enhanced monitoring, inspection action plans, especially from the regulatory perspective, the national reports, open incidents, and horizon scanning. So from an enhanced monitoring perspective, the biggest concern was the fact that we did not have a dashboard. Please report that the dashboard went live on the 1st of April. And that dashboard will be used by the quality and safety group from the service group as such, and will also be feeding into as part of the assurance report to the quality and safety committee and to the board too. From an HIW action plan, so for 2019, 2023, and 2024 have now actually been completed. They're all been completed. While the actions have been closed and improvements have been made, it is important to note that there is one theme of concern, and that's actually the bereavement room on Labour Board. And the service group is revisiting options to relocate this on a long-term basis. This is to ensure that the safety and the support is actually being given to the women of when they have lost a child. Moving on with regards to HIW, there was also an unannounced visit in February this year. And actually, again, pleased to say that was actually a generally positive report. They did identify areas of improvement, but none of which were actually related to patient safety or patient care or safety as such. And a draft report has been submitted back to the HIW with regards to that. Coming to the next regulatory action was with regard to HEIW, which is Health Education and Improvement Wales. There was a visit which happened in April 2025. The risk score was 12, which went up to 12 in December last year. There was also a concern last year that the fact that the GMC will be escalating the service to enhance monitoring. Again, pleased to say that the fact that the April 2025 visit was very positive. Its score has come down to 8. And also the GMC has written back to the health board to say that the fact that they are de-escalating the service as such. So we are no more at the cusp of enhanced monitoring from their perspective. One of the biggest things that I picked up as the SRO was actually the number of incidents. When I started the process, we actually had 230 open incidents at that time. But remember that the fact that the service reports around 130 incidents a month. We've been able to actually have to close it, and service group colleagues have been extremely helpful doing sprint events. And currently, at the time of the report, we actually had 88 open incidents, and that too actually being legacy, where there have been claims, redress, or the fact that so there are legal issues which we could not actually. So again, excellent progress has been made. So I should say, I'm pleased to report that the fact that the Gold Command achieved what it actually has been set down. As the Exec Director of Nursing has just reported, there will be a perinatal committee which will be picking this up to ensure there is robust governance, and also there is reporting mechanism both to the committee and to the board too. Which does mean that the fact that the last meeting for the Gold Command will be on the 2nd of June, after which a closure report will actually be going to both the Quality and Safety Committee and the Management Board too. So in summary, the Gold Command has achieved its task. We are actually moving more or less into business as usual with the perinatal committee. And before I conclude, I would like to also take this opportunity to thank colleagues from the service group, especially Kathy Greaves, Director of Midwifery, and Professor Sujoy Banerjee, Associate Medical Director, who's actually helped with regards to making sure these actions have been completed. And the paper has been come to the board for acknowledgement and assurance, and I'm happy to take the questions.
Thank you, Raj. Richard, would you like to add anything before I open it up for questions?
No, the report is comprehensive. As I'm sure the board members are, extremely appreciative of Raj's input on this over the past period. He's been instrumental in putting together all those outstanding actions that were there a year or so ago from the HEIW report, and to draw those to a conclusion. And I think as Liz picks this up as part of the perinatal board, we've got assurance that what has the recommendations of the past have been closed, and that we're in a position then to go forward with the recommendations and the action plan that arises from the independent review, and indeed to incorporate the recommendations that will come through from the Commission as well.
Thank you, Richard. Thank you. And open it up for questions or comments.
Thank you, Raj, and thanks to everyone who has been part of that Gold Command, because I think you've set the scene. You've certainly led by example, so thank you very much for that. One of the things I would like to understand a little more is the review of the Safe Now indices. So I wondered if you could just walk us through that. We've got 2 members of the oversight panel, have a planned meeting with the health board to continue the discussion about progress of Safe Today indicators. So I don't know whether it's you or whether it would be Liz who would be picking up that. We're developing a new range of board information. I'm not sure which one of you or both of you would be doing that.
I think, shall I pick that up,
Yeah.
Raj? So the intention is that the perinatal committee will have a range of indicators which are used nationally, but also we will utilise benchmarking data as well. So the dashboard is part of it, but there's a lot more around workforce. There's more around culture, feedback from women and families using our MVP. So we'll develop that through that perinatal committee to give us ongoing evidence of where we are and how we're performing against metrics and outcomes for perinatal care.
Really good, because I know, Raj, we've had a bit of conversation around how do we progress with the learning that we've had. And a couple of the conversations that we had in the Quality and Safety Committee has given us some more areas that we could look at to ensure that we've got that rounded, robust information that we need to move forward, Chair. So thank you for that.
Thank you. Denise and Ken will cover that, these points when they update us now, and there'll certainly be a huge section in the report itself on learning indicators, etc. So if we can hold that for a little minute, Denise and Ken will come to that as well. Any other comments or? Thank you. Well, Raj, I think the whole board extends our sincere thanks for the way you picked this up a year ago. it needed forensic leadership focus, attention to detail, being able to pull together a multidisciplinary team, very challenging circumstances. You know, we found ourselves in a position with recommendations that were 5 years still outstanding. It was a really tough leadership ask, and you have discharged that leadership role with distinction. And the fact that you can come and assure the board Gold Command has delivered what it said it would deliver, and you have our grateful thanks, and we hope you're really proud of the work that you've done, and you take it back to the team and say how proud we are of all of you. Thank you. Now that does bring us to Denise and Ken. So to give us an update.
So thank you very much for the invitation to come to your board, and it really is very nice to be here in person. I think it's much better than being online. So you've got the report, and I will take the report as read. Just bringing attention to some key points really. The first, I think, is the importance of the CLICE report. I don't think, you know, we have a huge thanks, I think, to CLICE for that report, and also for the heartfelt testimony from families. So that report is being used to contribute to our overall family engagement work. And so the feedback that we've had from the work that Ken will talk a bit more about shortly, from the engagement team, from what we picked up from Maternity Partnership Voices, and from the CLICE report, all of that is being put through a kind of technical kind of software content analysis approach around the themes, which is called Navivo, and that will form a very important part of the report. So I think a huge thank you to CLICE for that. We've also, in terms of any support to any of the family that gave testimony to the CLICE report, in addition, I know the health board helpline, but we've also have our self-referral triage midwife, Chantel, who will continue to be available if anybody wants to contact her, and we provided contact details of that. So that will continue, particularly any families that would like more explanations and would like some resolution from some of the things that they've raised, and that's incredibly important to us. You'll see in the report that our self-referral midwife will continue, and that will continue beyond the publication of the review and be supported by the health board, and that will give a degree of somebody slightly independent of the health board, but will work with the health board to help families get the answers that they need, and there will be something they can go to if they're not coming through the health board. The second thing is we're in the final phase now of the report. We are progressing with a plan to publish in the summer, mid-July to end of July, with a couple of caveats. So the clinical reviews are mainly completed. We are still in the process of completing the intensive care unit reviews. They are quite complex because there's quite a lot of reference for the clinicians to review. And we also have a quality assurance process for that as well. So I'm just giving you some indications that we will make sure this is a quality report, and so that's for us is our key focus, that this has been through all of our focuses. We also are doing some work on the Safe Now, as you just raised. We are two of our clinicians from the oversight panel, one of which has led a lot of the work around reading signals from the Kirkuk report around what does good look like in terms of reporting on Safe Now. How do you know what is the assurance that you would need to see as a board, and what assurance at every directorate level, and that is a key part of the report. And another part of the report will be the transition arrangements. So what will happen beyond the review, and I think Ken pick up. There's a point in the report around costs. We have the majority of the costs have been in the clinical reviews, and they are almost at completion. There is an important part of the clinical review team which involves making sure that there is effective feedback to families. So that part of it is still ongoing because we know that families may run out of time before they come back to talk to the clinical team. So the final thing really was to hand over to Ken. We have moved towards a large amount of our family engagement, but there are some meetings to continue. So if I just hand.
Thank you very much, Denise. We've come to the end of the active family engagement activities that we've been running. We have one further but important meeting next week in the Central Mosque in St Helens Road, and that will, I think, signpost an important opportunity for the Health Board going forward to engage with the communities around the area. The point I would make in relation to that, and a bit more generally, is that in the family engagement that we have conducted, we've been struck by the extent to which those families participating, even where they have had bad experiences, are ready to share those in the interest of improvement to the service. And I think this is the theme which I would encourage the board to grab hold of, because you can be forgiven for thinking that that's not the case on occasion, but that is the experience that we've had, and that certainly extends to the Muslim community and to the Chinese and Huaren community with whom we've had specific meetings and who have said that to us. So I would hope that the review will serve as a bridge across from the past that Raj has described to the future, and will be helpful in serving that purpose. In the meantime, our family engagement team remains in place to help support the women who are still coming forward as we complete the reviews, the clinical reviews, and so on, so that there's no woman who would be unsupported through this period. Clearly important discussions to come about how that transitions going forward, so that nobody is left in a position where they have nowhere to turn to, but whose concerns have been highlighted in this period by the Cleiss report and by our own report to come.
Thank you very much, Denise and Ken, for that update. Can I open it up for any questions or comments? Anne-Louise.
Thank you. Thanks both very much. Can I, it's perhaps going down into granularity, Ken, but at the meeting in the mosque, is it going to be simply focused on maternity care, or maternity care and paediatrics, perhaps older? And I ask because I know that for some families, they find it difficult, perhaps embarrassing, to come forward if they're having trouble with their children and don't know who to turn to, both from a health and a social care. And it seems to me that you have created a wonderful opportunity for us to be able to give better information for families to feel able to come to an open place, be able to help them with the whole business of bringing up.
Yes, certainly amongst the families that we've listened to at the Sketty Mosque are families who have older children, and issues have arisen in those cases. And I'm pleased to say that where we brought that forward for your attention, those issues have been and are being addressed, which is being noticed, I think, by the communities that we're speaking to. So there is, obviously not giving details here, but there are examples where there are either older children or children where the birth was some years ago, and there are continuing issues where those are being highlighted and where they're now being shared, again, very much with a spirit of wanting to see improvements. Issues around language, for example, where there are points to learn about in that.
That's helpful, and those things are being captured by.
Yes.
By
I think in addition, I think the value of this review, I think will be wider than maternity. And these kind of connections that the family engagement team have, and what Ken has said to me is that people are really wanting to engage with the health board, broader than maternity. There's going to be the opportunity there. And I think what this has shown is that some of these seldom heard groups are really wanting to meet and engage. And I think there's a real opportunity here.
It seems a golden opportunity to be able to do some of the things that we talk about in other areas.
Yes.
We've got the opportunity now. Right, thanks.
And I think we will, as a consequence, look to rework the way in which we engage, our engagement mechanisms. I'm sure that will form part of our overall work list in terms of patient experience.
Yeah, as Denise said, the learning for us is far broader than in maternity and neonates, and the organisation as a whole can learn and grow from that.
I think what I'm saying is that I'm detecting an appetite in communities that we are engaging with to be part of that going forward, and not to stand apart from the board after the report is.
Do you want to come in?
Well, just to reinforce, I suppose, the points that have already been made. I think the model of reaching out to communities that is sometimes challenging to get their input, and that's really, really important to us. So the work that you've done is a really good sprinkler for us there to be more effective, and also to build on some of the other work done as well in terms of some of the outreach workers that we work with who are working within the voluntary sector, and I think that's an important route in to some communities as well. But just the concept of absolutely co-producing and working with patients and service users is a critical one for us going forward, and that's something we're absolutely committed to and need to better articulate it, I think, because there is some good work going on, but I think there's a need to be more, for it to be more visible and more clearly understood.
I was just going to say, we don't need to wait to the report and to be concluded to do that. So I was just thinking we could use the opportunity tomorrow when we're together to grab a bit of time about the practicalities of how we can pick up the reins and do that, because we have got those examples where Richard described, but there's nothing better than us ourselves reaching in and our teams and picking up on the conversations that you've started for us to hear
I think that point is well made, because what I've seen happen before is that without intending it, a review of this kind can raise expectations amongst these groups, and then there can be a kind of gap when people can feel, well, was that really serious? And I think having something in place for that period would be important.
Jean, then Pat. Let me ask a kind of practical question. Given that you will be seen as the agents of change, and given your last comment about the lag time maybe from you contact with these people working with them and we as a health board picking up some of the future activity, if you were in Abby's seat, what would be the first 3 things you would do?
I think have a discussion of this kind would be the first. If I could say that without being too trite about it. I mean, I think there is something about acknowledging where you are now and doing so in a way which isn't defensive about that. I think then there are signals which you can send about the disposition of the health board to engage, and I think these would be signals that would be picked up and rightly interpreted. I don't think that's the change. Maybe hard one to come, but those signals of being interested in listening to people it's not that hard, I think, and it could be. I mean, it maybe raises issues of time and resources within Richard's area, but I think the ability or the need to send those signals when people would be otherwise, I think, wondering whether the investment that they've needed to do has had a continuing purpose.
Can I just ask, was your question specifically about family engagement going forward, or was it a broader one?
It's a broader one. It's the family engagement is one compartment, if you like. But it's if we only follow that one avenue, then we've lost everything that your reports would have given us from in the broader context. So it's understanding how we can use that to impact, well, not impact, but build a better interrelationship between communities and help enhance the pathway between primary care right into secondary care and discharge of the patient. So it's that overall encompassing aspect.
I think that the key, if you were to ask me, the key points of this review will be, are you as an organisation doing absolutely everything you can in terms of prevention and learning from harm, and that includes the way you investigate and the way you involve families in that. And the second is, are you doing everything you possibly can in your response to harm? So compassionate at the way in which that you've been talking about. So those are going to be the, that's the key driver of this. And if you get that progress and that right, that will then, for the whole organisation of all of your services, that will apply.
And please come in. Chair has asked they go the reference, please.
We had a brief update on paternity services at the last meeting. We're having a reset of the stakeholder reference group. But we agreed that actually this will be the main topic for our July meeting. So we want to take all of this learning and bring in our own 2 penny worth.
I think the other thing is, and certainly my experience, and I think from the engagement team, is a lot of our stakeholders don't want to come to meetings. They want you to get to them. And actually the meeting have got quite small groups. People don't want to necessarily be in huge groups. So I think certainly I've worked in the health service for many years, and I think traditionally we would kind of say come and be on a group or come and be on a committee, and actually I think it's turning it on its head and going there really.
Let's ask how you're going to weave in the recommendations from the classroom.
In the way really that I've described is that we have a sophisticated tool, which is a kind of content analysis. So all of the comments, everything that's come from the CLICE report, everything that's come from the partnership group, the engagement group, all of those are going to be used. It's absolutely essential that we capture everything, and also including the feedback from the self-referral families that have met with our triage midwife, and what will come out of the clinical reviews as well. So what that will do is it will generate themes, and we would expect this health board to already be working on those themes. There should not be surprises in there. The things that we've been talking about really that we just need some progress on. So it's absolutely critical to the review.
So can I just ask, is the tool sophisticated enough then to be able to confirm that all of the recommendations from the CLICE report and all of that are weaved into the independent review report?
I would say so, because I think those themes will be very much what we've described, and I think this, particularly the area around the CLICE report, it kind of still fits with that. What are you doing in the prevention space? How can you improve your response to harm, compassionate responses, and that comes out very loudly, I think, in the CLICE report.
Thank you. Well, Ms. Ken, thank you again, and particularly for taking the time to come and meet us face to face. We know that the executive and clinical teams are really looking forward to working with you tomorrow, and we hope that you will be with us again face to face when you do launch the report, because we will plan to have a special purpose board meeting at that time, so that we can give it the information that you'll need. So we will look forward to meeting you again then.
Thank you for having us. Lovely to meet you. Thanks, Raj.
Okay, we'll resume then. We are now going back on the agenda to item yes, we got with you, and you're going to start the
Thank you, Chair. So very briefly from me, I'm assuming about the paper, as the Chair noted at the beginning of the board, this is the first time that a full paper on dental services has been presented, certainly in my time anyway. And because it's the first time, the team pulled together a really broad overview of the dental services, and then if anything is requested subsequently, hopefully we can hone in on the specifics that that the board would want to explore further. So just in brief, so the paper covers the services that we provide, the issues we face, and obviously some positives from the services that we deliver as well. I'm certainly not the expert on dental services, so that's why Craig and Carla are in the room, so hopefully you can cover off any questions between you. On the beginning of the paper, just gives you an overview of our position with regards to dental services. You say we've got 52 high street practices, 2 specialist orthodontic and 2 specialist oral medicine practices. We're only one of only 2 health boards that have a dental teaching unit. That's a real benefit for us and for our population. We've got hospital provision for the more complex work that we do, and we've got the Design to Smile service and the Lasting Smile service as well for our very young and our more elderly population to support them. Page 5 of the report just provides some national context of where we sit with regards to the provision of dental services, which the board will be aware are being constrained across, probably across NHS, the whole of the NHS, not just NHS Wales. You'll be aware there's some significant contract changes recently with the General Dental Services contract. That's outlined on page 6. I'm sure there'll be some questions on that, and I'll refer you most definitely to Carl and Craig on that one. Page 9, just one other thing to flag, you'll be aware of the Dental Access Portal, which again is a new development for dental services, and for the first time provides a waiting list view for patients who are not able to access NHS dentistry. So relatively new for us. Currently, we've got just over 3,000 patients on that portal. It will increase, and we know there are 500 children within that waiting list for us at the moment. Just for context, there's circa 60,000 patients on the All Wales portal, and it's going to keep growing as we know dental services become more and more constrained. Worth noting, there's no additional funding resource for managing this portal or for the additional capacity that we need to do that. And then just the latter end of the report from page 10 onwards, this gives you a bit more overview of the more specialist services that we've got. So the community dental services, issues on the PEDS general anaesthetic service that is provided for us by a Parkway clinic, and specialist services for oral surgery and restorative dentistry in there as well. And just to finalise, note that our challenges in dental services everywhere gives you an overview of what they face, what they mean for us, and what we're going to look at developing going forward.
Steve, I'm going to ask you if you'd like to come in, given that Vice Chair has primary care in portfolio.
So, thanks for the introduction, Deb. It is a very comprehensive report, and as you say, it gives all the background information we need. I think there is a fundamental question that will be asked, and I'm still asking it, even though I've looked into it in great detail. Does the fact that somebody is on the dental access portal, who's not on the list of any of our dentists, does that give them any certainty that they will be able to get dental treatment if they need it? First, on an emergency basis, and second, on a sort of regular, checkup and hygienic basis.
Okay.
Given, as you say, that there's no funding for the extra capacity.
There are different arrangements for emergency dental. So if somebody does need emergency dental treatment, we have local provision which are provided through our GDPs. In terms of on the DAP, it is really, once they're on the DAP, it's a matter of time in terms of us identifying capacity within the local dental practices to be able to allocate those patients to those practices. So those practices have to come forward with capacity, because as Deb rightly said, there's no additional funding for this. To Carl, Jordan.
We're currently looking at the DAP to look at prioritisation of the DAP, because obviously there will be certain groups in that, for example, children,
maybe that we need to prioritise off in their best interests. Other health boards have done that in the past when they've had a DAP system in place longer than we have. So we're currently looking at that on an equitable basis. We've also got something called a stabilisation pathway, where individuals who can't access a dentist for whatever reason, but for example, going for cardiac surgery or cleft lip and palate, we take them into a stabilisation pathway, which manages all their dental care so that they're not disadvantaged from that side of things. And it's more than urgent care. They will provide all their stabilisation care. And again, that's another pathway that going forward, we may well want to develop. And that's a health board service that we deliver through the dental training unit. So that's outside our GDS urgent pathway as well. The DAP is an early beast for us. It's an early beast across Wales. And we're also trying to find out what it's likely to look at next year with some of the proposals coming through in the new contract, which opens up that DAP even more. But that is out for consultation at the moment, so we just don't know where that's going to be. But you know, DAP is obviously for us a major concern, but we're looking to how we manage it. On the good side of it, we have taken some initiatives at the end of last year to start taking patients off DAP by offering commissioning arrangements. That took a small number off, mainly children, at the end of last year, which hasn't been reflected in the figure that Deb says. It took about 200 off this month. And we've also gone out to practices for this year to say, you need extra new patients. We can't make you take it up the DAP, but if you engage with us, we'll provide a steady flow for you and guarantee that. We didn't have a very good uptake with that early on, but we just started to see now practices as they've gone into month 3, month 4, looking at their new patient target, and they've started to come back to us and ask us about providing patients off that. So at the moment, we've got about 1,800 patients lined up of 15 practices that said they want to take that, and another 15 are showing interest. So we're hoping that we'll start some of that, that's the way, I won't say inertia, the opposite word, acceleration off the DAP. But the other thing we don't know is the numbers going on to DAP yet, because we're early days with it.
So if a practice takes a new patient, given what we said about funding, that must mean that that's at the expense of an existing patient in terms of their being delayed for their next appointment.
Yeah, it'll become part of their contract. On the other hand, they may be taking some of those patients directly into the practice who may not go into DAP. At the moment, you can only go into DAP if you haven't seen a dentist in the last 4 years. So there is that momentum in there. DAP is a new challenge for us. So we're beginning to work some of those scenarios through, particularly in the light of new contract changes as well. Thank you.
Nicola.
Thank you, Chair. Thank you for the report. I'm delighted to see that we are discussing it at some length. I know it's come to quality and safety quite a few times over the last couple of years. I've still got some concerns over obviously the 3,067 that's registered on the portal at the moment. They've obviously been without a dentist for quite some time, and there's obviously no time frame for them to, you know, now they're on a portal, are they assuming, oh, you know, are we going to be seeing a dentist in the next year, 2 years, that sort of thing. I'm quite disappointed that Welsh Government aren't putting funding behind that, because I think that this probably should be one of the priorities that we are looking at. On a positive, I just wanted to finish off with the Design to Smile scheme. I think it's a fantastic scheme. Disappointed that only 49 out of 91 schools are taking part in it, and what can we be doing to sort of push that through? Because obviously if you've got children on the portal, if they are having access through the Design to Smile scheme, that will help those children.
If I could just come in for Caldas on the portal bit. So those patients were hidden from us before, so they're not new. They were not there. They were there. We just couldn't see them. So I think the portal now visualises those patients, and we all know what happens when a waiting list grows. That's how the investment becomes forthcoming. So hopefully, with the development of the DAP and the waiting list growing, that will give a bit more focus from Cardiff, and we might get some additional investment coming through or a change in the contract to reflect that. But I'll just let Carl answer the specifics.
Yeah, I just say we're looking at how we prioritise off that list, and I think children will be a high priority to come off that list, and that has happened so far. We've taken 180 off. I think Design to Smile is a good programme. It's now focusing on 5-year-olds, preschool, nursery, etc. school. It's a national programme, so there's always work coming out of Welsh Government to encourage schools to take on. It's only one in the toothbrushing side of things, but it's increasing the fluoride. So they're going into the schools, but the schools have decided not to take up the full offer, if you like. But then that's an ongoing educational issue going in there. Some schools take it on very well, others feel some of it is a disruption to education to do it. So it's an ongoing situation as far as that's concerned. And we definitely saw a fall off after COVID. A lot of that was infection control, toothbrushing, how you do those sort of things, but they've worked around those as well. So it's an ongoing encouragement and support from that point of view.
I think you'll see there's a large proportion that's taken up the fluoride varnishing, which is probably more, which is most effective, and that's one thing that would do in terms of in practice as well. So that sort of mitigates some of that gap. But it's sometimes in terms of engaging the teachers to actually have that time to supervise the toothbrushing, and it's really is a decision down to the schools to do that.
I suppose to add to it, sorry, never invite me to a meeting, so you won't stop me talking. So I apologise. The other thing is the education to the family. There's packs that go back out to the families, health visitors. It's all that engagement that's working on in the background, as well as the direct hands-on contact as well.
Anne-Louise, Jean, then Rita.
Thanks. Can I pick up the bit about retention and recruitment in the community dental service? I understand it's quite difficult across the whole country, I think, England as well, recruiting dentists into such things. But you say that there are staff engagement programs and so on. Have you any feedback on that? Why it's difficult to recruit? Why they won't stay? Are they being poached by other dentists, or is it just that there's more money to be made in private practice? Do you have an understanding of what the issues are that are making it more difficult to get people into the CDA?
I'm not sure we have sorry, I haven't got the detail about around what dentals of engagement event, but I suppose in terms of bringing, you're asking people to come into a salaried post rather than actually maybe potentially going into practice. So there's probably a differential in earnings, but also there's a specialist skill set required for those individuals who can actually come into CDS, and that's narrower because we are often dealing with patients with not necessarily, but the other demands, physical and otherwise. So it's a difficult field anyway to actually go into.
Is that not an interest that could be promoted?
It is for them, but
we're seeing healthy mouths all the time in private practice.
It's not necessarily the healthy mouth. It's actually the other physical issues that.
I understand that. It's just, it sounds as though in the community dental service you come across people who do have other difficulties, and therefore it makes the actual arts of dentistry, science of dentistry, more interesting. And I would have thought that might be an attraction rather than a disruptor.
Can I come in? I think that expectations of dentists coming out of dental school slightly different to when I came out of dental school, and you can see that on social media. I think in this health board, we turned the direction of the community dental service about 10 to 15 years ago. It was the school dentist to a specialist service, and primarily directed those who didn't need that into the general dental services, which is in their best interest anyway. So I think we made a move into a specialist service. And I think then you're quite right. There's a degree of education and exposure to young dentists to say, actually, you could enjoy this. So what we've done over the last 2 years is introduce hybrid posts. So they're part-time in the community dental service and part-time in the dental training unit. So in the dental training unit, they're doing routine dentistry, teaching, but in the community dental service, then they try to manage it. Now, we've had a good take-up of that because the people have stayed into those posts. So we're now doing a piece of work to develop a career pathway, if you like, to say, if you come out dental school and come into the DTU for your first year, you've got to come options here. HEIW do a number of those, but these will be more customized to the needs of our population. And we think the young dentists will be more attracted to that because they can still do the dental side they wanted to, and they can even be in private practice, where they come in and do 2 or 3 days with us in the suit, doing that specialist work and learning those extra skills like sedation, general anaesthetic and those things. So we've had a good response to that over the last 2 years. Now we're going to try and map that out over a 5 to 10 year period to see what that workforce would look like.
That's really positive. Thanks.
But there's 2 more then, Jean, then Rena.
Given the narrative that you've supplied around the regional general anaesthetic service, can we be assured that none of our population are coming to harm due to some of the things that you've pointed out in that narrative?
So
Is that the pathway?
It's the
paediatric budget.
Specifically.
Because the problems of closing Prince of Wales Hospital, that kind of information. You say here that the programme is starting again in September 2025, or this is starting again. There seems to be rather a gap, and I would like comfort to know that none of our patients are falling down between those goalposts, if you like, and coming to harm.
So we can't give that assurance at the moment because there hasn't been a service provision for them unless in really urgent exceptional circumstances we've managed them. The provision has always been through the Princess of Wales facility in Bridgend. And obviously when they lost the roof and had to go through the major works, our service was one that suffered as a result of that. They have given us 3 separate dates for getting that service back in place. So I think the first was August last year, February this year, April this year. We've now been assured it's August this year that service will be back up and running in the Princess of Wales. We have looked at what we could do in the interim to manage these patients, but they are really complex patients to manage, and that's why the familiarisation of the unit that they're used to and getting them used to that environment is really important. So it's hard to recreate that in an ad hoc way to get those patients through. But Carl and the team managed to make sure that the most clinically urgent we can prioritise and get them through. But certainly, as a result of the delays, some of those patients will have had distress as a result of their treatment being delayed, I would say for sure.
So can we be sure, or as sure as we can be with the goalpost being moved, can we be sure that those that need us most are actually getting the services that they need?
Yeah. So I've spoken to the Chief Operating Officer in Cwmtaf directly because the goalposts have moved. We understand why, so that their plans have not come to fruition as they expected. And I have had assurance. I said, look, are you definitely getting the service back up running in August? Otherwise, we're going to have to look at a long-term service provision outside of the Bridgend area because we have to provide this service. I've had that assurance that no, August will be the day that these lists go back in place and we'll then manage those patients.
So we are looking at contingency plus.
We are looking at contingency separately for children and adults because we need to look at the in terms of what they require. And obviously we are building a waiting list here, a bit more of a waiting list. So I think even when we restart the service in POW, so we'll still need to look at is there something that we can do locally to deal with some of these individuals so we can reduce that waiting time further.
Gina, I'm proposing that we remit to Quality and Safety Committee the ongoing oversight of these risks. And this whole question of looking at whether harm has accrued, any avoidable harm, how we avoid any further harm. So we'll remit that to the committee if that's okay. Rena, final comment to you, please.
I was just wondering about, particularly within the DAP list, have we done any analysis to see where these patients who are clearly not without coverage are in our area? Because I'm particularly concerned about that in the context of the fact that we know about the issues of equity. The other thing is in the context of this CVO or whatever it stands for, I can't remember, for the contract arrangements we have now, do we have any control to ensure that the dentists maybe that have got less patients for whatever reason, people die, people move, whatever, are actually taking people off the DAP?
There's no obligation to take patients off DAP at the moment, no obligation. And each practice under contract reform has a target for new patients. So they can fulfill that from, they may at the moment have their own in-practice waiting lists. That's due to change from that perspective. So at the moment, there's no obligation. What we've been trying to do this year is encourage them to come to us to take patients off there because it gives them a degree of predictability. Particularly as this year, they're targeting the NIP patients, I think it's gone up by a factor of 3. So we're beginning to see those inquiries coming through now. Proposal for next year, contract reform, is that new patients have to come off the DART. But that's purely out for consultation.
And have we done any analysis of where the patients on the DAP are?
At the moment, we can only do it by their home postcode. That's how they register. But we've only been running this now 2.5, 3 months. So it's really early to make any firm judgments on that. We got broad with the Swansea and Neath Talbot, but we haven't got the breakdown within that at the moment because it is very early stages with it.
I suggest, Chair, that maybe you can Quality of Safety do in their overview, that we particularly look at that distribution, because I think that is quite key.
Well, we did indicate this is the first of a series of primary care updates, and it's obviously very welcome. A really comprehensive overview. Thank you very much, Carl. Upgrade generated a lot of interest, so we welcome it. We can obviously take assurance of some of the positive developments in the report, but also we do need to register the concerns we've had around the risk, and we are remitting ongoing oversight and action and see what we can do to mitigate those risks to the Quality and Safety Committee. Thank you.
Thank you, Chair. Thanks, Will.
So we move now on to part 5, our people session, and we would like to take us through the key issues from workforce development.
Yes, thanks, Chair. There was only one element from today, and in some ways it is relevant in the context of issues we've already discussed today. This risk around workforce planning. And although we were given some assurance in particular areas that the workforce planning protocols are being put into place, what we were concerned of, this wasn't consistent across the board. And therefore there was a risk that we felt should be included in the risk register, because this is clearly key in terms of the continuity and the sustainability of our services, that we are effectively workforce planning. The only other areas were in relation to the assurance, and there before you, I don't think I need to add anything, because most of them are areas we've covered before. What I would say is we're still continuing to focus on things like attendance at work and sickness, and obviously recruitment and retention. So you can see the sort of emphasis within this, which are the priorities for the organisation. Thank you.
You'd like to answer?
Yes, on the workforce planning, so that's my background. I do like the HEIW framework that we've been using for workforce planning, but I've agreed with Lisa Haldal that I'd be the lead across both the health boards to improve the capability and capacity of workforce planning across both organisations. So watch the space, and I'll bring an update to a future meeting.
We're happy to take assurance then on the update and the ongoing work from this. Takes us on to 5.2 then, and Tina, we turn to you again for the staff survey.
Yeah, thank you. Just wanted to start this agenda item by saying that I really value the importance of the staff survey, in a couple of reasons for that. One is as a board member and director of Workplace and OD, it's a really helpful mechanism to obtain soft metrics. So you get hard workforce metrics through turnover. We don't very rarely get this what I call soft sort of staff experience metrics. And it's a standard set of questions that enables us to benchmark, but also to develop a heat map, so we're really clear across the organisation where we've got good and poor practice. So I really advocate for the staff survey, and I'll be exploring, once we've got this running as it should, some pulse surveys throughout the year as well to make sure we've got really live information about staff engagement across the health board. For me, I think on coming in, it's quite disappointing with the participation rate. And when you have low participation rates, you usually get somebody either that wants something to say, or those that have got access to computers to fill it in. So the more rich, the higher level of participation rate, the more rich data you get. So that's one of the key issues for me to focus on to increase that participation rate. Feedback from colleagues on why they haven't to date is about the concerns about the confidentiality. So we need to work with our staff side colleagues and others to make sure people are confident in that. and also a lack of confidence about that was a point because nothing will change. So that, you know, we really need to own that. For me as a line manager, I really welcome the staff survey because it tells me my results of my direct reports. It allows me to get the hot topics from their perspective, and it's my responsibility then to work with my direct reports on what we're going to do to respond to that feedback, how we're going to measure whether we're doing the right things, and gain their confidence that things will change as a result of that feedback. So that's every line manager's responsibility across the health board to do that. So the bits that I just wanted to draw out from the report, and I'm going to take questions. So rather than tackle everything that's in the feedback that we've received, and over 2,000 members of staff took the time to complete the survey, we wanted to focus on 3 themed areas. So improvement around leadership and management, which will then see an improved staff engagement support to get that right. The psychologically safe culture, so speaking up safely and raising concerns. And again, therefore, we measure a success with that around we are able to speak up as an improvement staff survey. And also links to the bullying and harassment indicators within the staff survey of values and behaviours, but some work around that to make sure we are inclusive and compassionate going forward. Also want to draw out that it wasn't all negative. We really saw some positive feedback and some themes through the survey. What came through quite strongly was immediate team and colleagues, so teamwork was coming through, so real strong ethos here, which I've noticed since joining the organisation as well. Job satisfaction, so people do see the value of their work and the benefit to patients through that work, and colleagues, their commitment to wanting to go above and beyond to ensure that we provide the best service that we can, and a deep commitment to their roles and patients. So next steps are we're working with all the service groups and corporate areas. I've got an agenda item on the June Quality Committee to take those plans away from those, which is this next layer down, the actions that are being taken at that level to feed into those 3 priorities.
Thank you. Thank you, Tina, for that overview. Nuria, I know that you'd like to come in and open comments, questions.
Thank you. Thank you. I found that update that verbal update really reassuring. So thank you for that. Because actually, I would like to really thank staff for filling in the questionnaire. I think it's a really important heat map of where we're at as an organisation. And you have highlighted the 3 priority areas that I've highlighted when I read the report in terms of actions that we need to take as a board. For me, 1 in 4 staff felt bullied or harassed by their manager, and 1 in 4 by a colleague or patient is really worrying, and we need to get on top of why and what we're doing as an organisation. We spent a year focusing on the big conversation and on the Swansea Way, but it's clear from what I've seen previously being set in this board and looking at the staff survey that we've only just scratched the surface. So I think that turning this around is really a priority for us. We know that we have a limited assurance report and speaking up safely as a board too. So I think your focus on leadership is absolutely right, and something that we need to do around culture and compassion. So I really welcome that, Tina. I guess that what I'm really seeking for is that kind of assurance that you're going to give us that information in terms of the next steps, and that we will see the progress over time, but also that we will see this broken down according to services, because last year we saw a breakdown, and Morrison was particularly worrying in some of the statistics. So it would be really helpful to see that breakdown of services moving forward.
Yeah, so that level of information is going to the ward committee, so we can provide an update through the committee for the next meeting, if that would be helpful.
Thank you. So that's okay, Nuria? That sort of breakdown will come in the paperwork coming to ward in June. Thank you. Thank you for those comments. Any other comments or questions? Jane?
Just one comment. Whilst it's soft information results that we have, and we've been exploring the soft areas of behaviour, one of the things that I wonder is there any way we can get information by role?
You can do it by staff group, but not role.
Right. Okay, because we talk continuously about leadership development and leadership and management. So, and it's hard really to correlate some of this to where it sits within that profile of training people on performance management.
Yeah, so there's sections on there about my manager.
Yeah.
So we will have that, depending on the number of people that completed. So if it's a minimum of 10, we go down to that survey, special needs area to have a look at.
Yeah.
So we can do some further analysis around that. But I'm also working on a soft piece of work on organised success, which will be looking at the management capabilities and competencies in the organisation and what development we need to put in place around that. But I'll take that point on board and bring that back.
Annalise.
Thanks, Tina. The number, the overall number is disappointing because it doesn't give as good a picture as would be helpful. You mentioned in your introduction that you were considering doing some minor pop surveys.
Yes.
Through the year.
Yes.
Will that be all groups of staff, or will it concentrate on some service areas or break down some of the questions? Because some of the feedback that I've had in my previous role was that it takes too long, too many questions, it gets very boring, can't be bothered, very unpositive things. And other people really love them and like to fill them in. And I just wonder whether those become more targeted.
They do. It's usually about half a dozen questions, which about measure the staff engagement score, because that's really important for me to be able to monitor where staff engagement is. But we also have the opportunity to have a specific issue or trend that we want to ask about. We cannot have those in. So it's a maximum of about 10 questions, but it does give us like a quarterly update. So you usually run the 4 survey in Q3, and then 3 further pulse reduced surveys in the other periods.
And in your experience, has that generated better, richer data?
Yes, and also I would like to set the staff engagement score as a key metric for every line manager service area to own. And then the only way you can measure whether they're progressing with their staff engagement is through the annual survey and pulse. That's why to me it's really important.
Rena, last point to you.
Just a quick one. Given that one of the reasons, and I think it is legitimate, the lack of confidence in anything would change as a result of the feedback, I think what is important is that we get feedback back out to the staff quickly on what we're going to do as a result of last year's survey before we embark on this year's survey. And I think that's been part of the problem, that there was a delay in that, and that's why people felt, well, there's no point in filling it in. So I do feel that's a key thing we've got to do. So if we get the report to June 1, we then have to make sure, Richard particularly, that we get the communication out to staff, that what is going to change as a result of what we hear from the survey.
Thank you. So Tina, we obviously welcome the focus on the staff survey because it speaks to the role of the board in working with staff to set the tone and culture, and engagement is a fundamental part of developing the right healthy culture. So we support the 3 priority areas you've identified and support the next steps you've outlined. And obviously we remit to Board Committee the detailed oversight of the board, and we look forward to hopefully ways in which we can increase engagement in 26, 27. So, Dr. Barger, thank you. Let's return to the nurse staffing act now.
Thank you, Chair. This is the annual assurance report and covers the period of April last year to April this year. It is a report that measures our achievement against the Welsh Staffing Act, which is very new to me. However, I am used to taking a biannual staffing report to board. It is around that annual assurance, and it's to hopefully give you that assurance around whether we meet the Staffing Act. It has got a lot of information in there. I don't intend to go through the report. I'm just going to highlight some areas. So, calculation of nurse staffing levels in 2024 spring and autumn is in there, and has gone through management board, and all areas are aware of what their outputs are. We are going to do recalculations this spring 2025, and they'll be included in a board report to board in November. It reports our workforce and OD strategy, so it is just about the calculations. It is around our strategies, and the All Wales template is used to share information about incidents and complaints related to staffing, and that is about across both adult and paediatric wards. I will remind the board, and we have had this conversation in other arenas, this Act only covers 27 of our wards. It's adult inpatient wards and paediatric wards, and we have a lot more to do, I think, to understand the needs of other areas of this organisation, such as mental health and community, as well as our emergency department. And there are tools and processes that we can use for that are evidence-based. So this is evidence-based. We need that evidence base elsewhere. And I would also say, and I know Chris will come in and say it anyway, it is only around nursing and midwifery. And we really do need to think about how we assess our workforce resource and how we're utilising that resource, and are we making the best of that resource, but also encouraging development of those individuals across a number of professions, not just nursing and midwifery. As I say, there's a huge amount of information in here. I don't intend to go through it, but I'm very happy to take questions.
Any questions?
Hey, excellent. Just going back to a point really that refers back to the finance conversation we were having earlier. Obviously now we've been very successful in recruitment, and we're at or above statutory establishment levels in many of the areas. And it's concerning then to see that the variable pay is still at 2.5 million a month, which is 30 million a year. I know that the reasons for that, some are documented. I know it says vacancy 26%. I'm just wondering what the accuracy of that is really. I think you referenced the fact that you're going to look at the accuracy of coding, but also you've referenced, work that's going to be done on sickness and unavailability. And just asking really about how is that going to be progressed at pace?
Yeah, I mean, this paper, as I say, is to meet the requirements of the Act, but we have put more information in there. We have been incredibly fortunate to recruit in the way that we have, and we now do not have registered nurse vacancies across the board. We might have some pockets of that in certain specialist areas, but generally we are fully recruited to our establishment, which is an evidence-based establishment in those areas. And in fact, we're over-recruited because we committed to taking our internationally educated nurses, and we commit to taking our newly qualified student nurses, and we've done that again this year. We've talked about agency spend coming down. There are some areas where we're using it in nursing and midwifery, but there are specific reasons and rationale for that, and we've got plans to work through how we come away from it. So this continuation of the use of bank and the increase is difficult to understand. And I think, and we referred to it earlier, we had a recovery and sustainability board yesterday. My question was, please help me understand how this can be happening. I think we are going to have to take some very radical action around that to be able to stop, look, understand, and then move forward. I think some of that will be increasing our controls around sign off and around validation of whether staffing is required or not, because ultimately we are fully recruited. We have a very good uplift of 26.9%. So we recruit to establishment and then 29.6% more. That is full at the moment. So it does give us less flexibility. So a lot of work to do. We're underway with that. We committed yesterday to meet the directors of nursing. I'll meet with them and we'll get our strategy together. But we have to take some radical action to really scrutinise and understand the use of bank. There will always be an escalation process, but I think we're going to higher the levels of escalation.
Thank you. Jean, please come in.
I have 3 questions, Chair, and I'm happy to take them offline if it's my ignorance. But perhaps we can pick up for you to explain later. But some of the things that I read in the report, which I found very comprehensive, thank you for that, was statements like nurse staffing levels, section 25B. How do we inform patients of the nurse staffing level? Was my first question. Then on page 8, we mentioned the independent All Wales ward nursing assessment that's being conducted. Have we seen the figures for all of the health boards across Wales that we can compare and contrast what we look like against that? Then page 27 and 28 baffled me, which I've said on more than one occasion that you could do that quite easily. But statements like the roster has been agreed, but then it wasn't met. Just let me turn that up so that I'm not speaking gobbledygook to you. Yes, we've got the table that shows on page 28, total adult, paediatric. Then you've got the 5 columns running along which say shifts were planned, roster met but not appropriate. Then shifts were planned, roster not met but appropriate. I found that a bit confusing.
Yeah, it is confusing, Jean. So I'll start with that. So that is, we plan a roster, we plan it in advance. We've already established the numbers that we think we'll require for that roster. On the day, we might meet those numbers, but if somebody goes off sick or something happens, we might not meet those numbers. Now that might mean that because of the acuity of the patients and the dependency, we can manage in that way. And that would be roster not met, but okay. And then there's another bit, which is roster not met, and we need to take some action that day on that because of the acuity and dependency of the patients. But I'm very happy to take you through in more detail. It is extremely detailed, and these things are the things that we've been mandated to report. It's not easily understood if you're not in that world all of the time, to be honest. The other piece is around can we see the All Wales basis? Yes, we can. We've just had that out so we can compare ourselves on an All Wales basis with some key metrics, not all. But we do meet as EDONs and share information and compare and contrast and benchmark across Wales. On 25A, yes, we do. We display posters. We've got material that's provided on an All Wales basis that is out in our ward areas, and we do ensure that that's updated so our patients will know how many should be on shift, who's there, and where they can ask questions around that.
Thank you, Chair.
Okay, thank you. So we're receiving this, the annual report, and there's on the basis that is, it's a statutory requirement of us. So it's compiled accordingly. And we're acknowledging and supporting the additional work that you're putting in train. And surely the board committee will, where appropriate, sort of taking over the side view of how that work was going. And can I ask that if anybody does want to have a more in-depth tutorial with you on the mechanics of the staffing, and you would be happy to set it up.
Very happy with the aid of a very, very good nursing workforce team that are teaching me as well at the moment, but yes.
Thank you, thank you. Right, we move into section 6 then, governance, and as I said earlier, it is the board's role to maintain good governance across all domains. So Nuria, maybe start this section, please, with your update from Audit Committee.
We've had 2 audit committees since the papers that you have in front of you, but we haven't agreed the minutes of those audit committees yet. So I'm going to concentrate on the paper that you have in front of you. So in relation to today's paper, I would like to alert the board that the committee received 2 limited assurance reports from internal audit on asset management and quality assurance. We referred these to the relevant committees for scrutiny. The committee has continued to identify gaps in the audit tracker, with executives not updating the position in relation to audit recommendations. Also, our executives are behind against all Wales indicators in relation to time it takes to respond to internal audit findings as part of the clearance process. And I would like to draw the board's attention to a couple of issues that we referred to other committees. Firstly, the committee was concerned about an apparent lack of ownership and curiosity around savings from outpatients transformations, where we've brought which we thought may be an indicator of wider issues around savings from service transformation. So we referred that to Performance and Finance Committee. The second came up as part of the audit planning documents, which showed a consistent under-delivery of some key services in primary care under the GMS contract. And we were concerned that they may have implications relevant to the work of the Quality and Safety Committee. So we've referred that issue to them. In relation to support that we're seeking for board, we would like support in particular for the following actions. We would like to take a zero tolerance approach to delays in addressing high priority audit findings that impact on patient safety and quality. We would like you to fully contribute to the review of the risk register as part of the reset. And we would like the board to fully contribute to the review of all the policy documents to ensure these are updated into our tracker and any changes are documented and communicated appropriately. So that's the support that I'm seeking from all of you today.
Thank you, Nura. That was a really comprehensive update.
Jan, before I finish, there is something that I absolutely need to do as chair of the audit committee. I finally need to bring to the attention of the board that we agreed a debt write-off in excess of 2,500 in accordance with FC10 income fees and charges. That's all from me, from the audit committee.
Thank you. So Nura, you've raised some really important points there in respect of responses to those. Who's leading off? Is that a matter for you?
I can pick up the bad debt write-off, and
Yeah.
in the spirit of public board, I won't give case specific details, but it's fair to say that debt was pursued as far as we possibly could. At the end of that process, the individual was subject to a voluntary arrangement, which meant that health board recovery would be very, very limited. Would be at the end of the debt trail. So in accordance with the financial control procedure, audit committee supported the write-off. That's 500. We disclosed the full service please, Chair.
Are we happy? Are we content to? Thank you. So Nura, come back to the zero tolerance one. You're looking for zero tolerance of go on, you say it again, please.
So we're looking for a zero tolerance approach to delays in addressing high priority findings, audit findings that impact on patient safety and quality in particular.
Yeah, thank you. Yeah, we will take that away and have a look at that, and that seems a reasonable ask in that sometimes there are some things that take us time to work through in terms of the recommendations. But as Nura's identified, this is about things where we would want to make a rapid response because it's flagging something to do with patient quality and safety.
Thank you, Nura. Is that okay? Executives that away and look at that. And then you're also asking for everyone's engagement. Yes? Do you want to
in the reset of the risk register? So we looked at this in our last audit committee meeting, and I think we made a couple of observations and changes that are being now looked at. But I would really welcome the views of the full board and your contributions to actually ensuring that we get this right. It's important for all of us. And then the other side is reviewing all our policy documents. So we had our first tracker on where we are as a board with policy documents. And we know that there were some that needed to be updated, others that needed to be documented in different ways. And again, I seek the board's full support in ensuring that they review the policy that they are involved with and that is placed in the tracker and an update can be provided to the audit committee in a timely manner. I wonder whether Hazel may want to come in.
Thank you. Any other members of the audit committee want to add to these points? Yeah, supportive. So we're looking at everybody's engagement in the update and reset of the risk register, and also in addition to what we already said about zero tolerance, we also want to be fully well, what will be an ongoing review of policies, won't it? So people are happy to support this work, and it would come back to a board development session.
Yeah, we've got a board development session in June on the strategic risk register and risk management report and risk appetites.
Yeah. So Nuria, the board development session in June can pick up a number of these points, but we can give support to the proposals from the committee today.
Absolutely. I think if we all go ready to that board development session, having read the policy documents and ready to engage, I think that would be a really good start.
Okay then, Nuria. Thank you very much. So, and thanks to you and members of the audit committee for, the rigorous work you do on behalf of the full board. Thank you. And Louise, we turn to you now on the legislation committee update, please.
Thanks very much, Janice. There's one alert, and it relates to an item that's been on the risk register now since 2017, relating to the employment of best interest assessors who look at mental capacity act assessments and deprivation of liberty safeguards. The Health Board does use external PIA assessors as well, but we are an outlier insofar as we have only 3, despite the number of patients and the size of the Health Board. The usual number is at least 7, if not in excess of 7. What I can't tell you is whether that makes a significant difference in other health boards, because the problem for each of these assessors is that each assessment can take days and days, and it can drag on over some weeks because of the information that's required, the involvement in the process with both clinicians and family members, etc. But at the moment, we are struggling to get these done in a timely fashion, which does have an ongoing impact on patient care, on discharge, etc. And the fact that it is something that's been known for such a long time, we felt that it had to come to this committee simply because we're not doing anything about the fact that we haven't got enough to be able to provide proper service to the staff and to assist to the patients and to assist the staff.
I think you have raised this before.
Yeah, I think we have, but we haven't. It's particularly in respect of the risk on the risk register. We've raised the level of the risk, and the other thing that I simply like to draw to the board's attention that arose as a result of something Jackie Daves reported in from the hospital managers committee, which is that there are significant delays in the production of reports, timely reports for hospital assessments. The hospital managers ought to have the reports about a week before the hearing, but often don't get them until the night before, and there can be quite a lot of papers, and they find it very difficult, which is not good for the patient. It's certainly not good for the hospital managers who are looking at the situations. And it's just really to advise the committee that although we raised it, it is an ongoing problem. I suspect it's because people are very busy and they find it difficult, but actually coordinating these reports is not as good as it could be.
Yeah, do you want to come in there?
Yes, thank you, Chair. Thank you, Anne-Louise. I guess worth exploring, because it doesn't just impact on mental health beds either. It's our general provision now. The number of best interest meetings that we have to undertake is rising consequentially across because of the frail elderly population we've got in. And it's worth looking at, are the delays because of the lack of best interest assessors or the complexity of getting the families and the clinicians together? And it's generally when we go, because we discuss these every week when we go through the clinically optimised patients meetings, it's that joining the dots on all of this and coordinating them to come together. And generally, it's the outcome is a competing need for the outcome. Family want one outcome, clinicians are looking for a different outcome. So therefore, the willingness to come together to discuss that and on the family's part is difficult. So it's whether it's more best interest assessors we need, or perhaps more support to coordinate them and making sure we've got the right coordination going on with those. But it's certainly an issue in terms of the number of best interest meetings we do and the outcome and the coordination of them.
And I think the extension of time, because there are fewer assessors, contributes to the family's frustration and also very often the deterioration of the patient. So there is a knock-on effect of not having sufficient assessors.
So what action are we going to take?
I can have a look at that if you like. If you want to send that to me, because it could be that we might only have 3 within the mental health service, but we'll have more in other hospital sites, and therefore we need to create a pool of best interest assessors, which may be able to support more broadly. But I'll have a look at what we've got. Yeah.
Thank you. Thank you for that. And Nicola, Charitable Funds Committee.
Thank you, Chair. I wanted to say a special thanks to our co-chair, Nuria, for her work until I took over. Just one thing we wanted to advise the board, we did have some concerns about the volatile financial market, and unfortunately Bruno Dalton were not available to attend the last meeting. We've been assured that they are attending the June meetings and we'll be able to feedback on that one. And just wanted to give assurance to the board that the charity team have had a restructure, they're aligned and everything's approved with the strategy. There's been some incredible work with rebranding and the development of online presence. And I think the team, albeit very small, done an incredible job, especially with the Cwtch Close for branding. I think especially within the Swansea arena. I know that they were falling short slightly for the Cwtch Close target. I know a lot of exec members have taken part in the fundraising. I've taken part in it as well. So I just wanted to encourage members, if where possible, if you could take part in any fundraising, I think that would be really, really great. And I think that's it from me.
Richard, do you want to add anything?
Well, just to say, I think the Cwtch Close is a really good example of where, yes, there's value in terms of raising funds for a good cause, but the engagement side of things, I think, is really, really important as well with staff. And I know the staff in the neonatal intensive care unit are, particularly grateful for the work that's been done. I think it's really important on both fronts.
So we can put on record our thanks to Nuria as the outgoing chair, and to you, Nicola, for picking this up and take assurance from your report. Thank you very much. So we've talked earlier about our performance and assurance framework. So long awaited.
With a joint committee.
I'm sorry. Oh, I'm sorry. I've forgotten the RGC. So Hazel, you taking us through this?
Yes, there's no notes and just some matters to make the board aware really and advise. Committee approved the governance arrangements. Public Health Wales led a presentation on establishing a South West Wales Regional Health Economy, presentation on the work programme from the Clinical Services Plan, and then an update on plans to hold a learning event in 26-27 was discussed, and the chair of Hywel Dda has taken the lead on that and overseeing the group for that work to take forward. Presentation on research and development and commitment was given to appoint a shared regional research and development director. I think that's really positive in terms of joint work in there, and those are just the main matters I wanted to highlight, Chair.
Thank you. And we are, Abby and I, Neil Wooding and Phil Clear, we are attempting to get some resource from Welsh Government to support this whole regional agenda, given that it is additional. So thank you. And thanks to Hazel and her counterpart Jo Wilson for the support. So we can come to you now, Darren, on performance and assurance framework. Over to you.
Thank you, Chair. So the report and the associated appendix set out the revised health performance and assurance framework. I'll come back to the name in a second. And the framework has been through both the management board last week and through performance and finance committee this week. So board can be assured of organisational and committee scrutiny of this. The document is here at board for ratification based on the steps that have been made for this. And in summary, what the document aims to do is strengthen the previous health board performance management framework, which is a slightly different iteration of this. It sets out clearly the new rhythm of routine monitoring for performance arrangements in the health board, which will be monthly for service groups, quarterly for corporate directorates, and a single quarterly cross-system performance meeting as well, which will include everybody in one room together. So it just takes a different perspective on that. It attempts to align external internal escalation methodology, so there's clarity about things will be escalated internally, and the diagrams in the back of the document hopefully clearly show how things change through those levels of escalation and what the interventions and support will be within the organisation for that. The whole philosophy of this is, yes, it's based on accountability, but it's a clear framework that should support rapid early recovery of areas which fall off trajectory in a supportive and values-based way. Should they not, the escalation is available, the accountability comes into play. And what it also does is sets out expectations of cascade and performance arrangements within certain corporate directorates. And from my perspective, lots of those are in place, and what this does, it puts the glue in the middle between the actual work that goes on in certain corporate directorates. In terms of feedback I've had from 2 preliminary meetings, very clearly needed to call this performance accountability framework rather than assurance. We're wise and happy to do that, but as the papers all went up together, I've had a chance to change that. It is clearer on the fact that escalation can be an individual performance area. It's not system escalation or escalation of the delegated area. It's specific performance areas within. Feedback of the document appears to be robust and helpful, which is welcome. It needs to avoid duplication of other performance arrangements as well. This is an increased frequency of meetings with service groups in particular. We need to make sure that they're effective and the time is used wisely. And comments particularly from service groups are asking for clarity on the key metrics which will form part of the assessment. So the proposal is we would have a core spine of common metrics and then specific metrics related to each individual service group area. That work is underway, but not. Just in the spirit of the previous paper on the regional joint work, I've met with colleagues in Howell that were lending us some of the technology and digital capability they've got around a single dashboard, and the SQL scripts that drive that would very helpfully allow us to produce one version of the truth, both at this level and other levels, and prevent service groups spending a lot of time, which they did do with due diligence, to produce their own presentations on their own performance. So it effectively moves performance into a regime a bit more like finance, where the truth is told in the numbers, the debate about the improvement is put there. That is work in progress. That will take a number of months, but we're on that track as well. So what I'm asking for today is to note the comments clearly from, and accept the comments from the previous discussions we've had prior to today. And I'm asking for the framework, subject to any further changes at board, to be ratified for use in the organisation. Thank you, Chair.
Clearly, an awful lot of work's gone into this. In fact, we know, as you said earlier, the FC has gone through it and given it a seal approval. Yeah. Any other comments or questions on the framework? So I think we're happy to speak.
So I asked a similar question at Performance of Finance Company. The escalation measures, we're mirroring the Welsh Government escalation levels. I assume we're going to be looking at more sort of on a more micro basis. So as you say, smaller areas of performance rather than whole groups or departments. And are we going to be tougher for the Welsh Government in escalating? Because I think we need to be there before anybody else is there.
So the idea of this is we support early and act quickly.
Yeah.
So that will come with its own risk, because we may have quite a lot of those initially that we're dropping a framework on the next out position. But yes, we will be tougher, and we need to make sure that we can support the recovery in those areas as quickly as possible and have this step change in escalation where the burden on the team and the organisation is such that it seems like we're obviously trying to act. That would be to get ahead of the curve would be the very nature of this. Exactly. But
Jane, oh, may I tongue in cheek? I agree with everything that's been said up to now. But picking up that point about accountability and Steve's point about being tough, some of the wording in there, when I read it, I thought if I wanted to be a bit of a stirrer amongst my team, when I read we would be held transparency and accountable when performance drops below the acceptable level. Shouldn't that read held accountable at all times? Not just when it falls below an acceptable level. And then the last one, which is the dragon coming out in me again, I'm afraid, is where you have all staff to promote a culture of delivering high performance in any way that they can. I think that's a bit dangerous if we don't refer to safety, everyone's safety.
really helpful. Thank you.
But that would be someone like me stirring the pot.
So, yeah, we'll amend it. Yeah, we'll amend those. Thank you very much. And we'll pick up the sort of early intervention point. You know, get it early, be very robust. Does it also as well set out ways of getting out to this picture, which is not something that the Welsh Government is very clear about.
The learning for us is, as soon as escalation is mentioned, we need to be absolutely crystal clear what the de-escalation is in that moment, and agree that collectively. So that will be the spirit. Clearly, you can't prescribe that, depends on the area.
Thank you. So we can agree the escalation triggers, agree the change in the service group performance review frequency, and then it's for the board to approve the framework after being supported and recommended to us by the Finance Committee. Is that okay?
Thank you very much.
Okay, thank you very much. So we've already done 6.6. So Hazel, we're moving to you now.
Yes,
6.7.
This is part of a routine report that comes forward on corporate governance matters. Just two items I just wish to bring to the board's attention. We've reviewed the private board protocol and just making one suggestion following the annual review, the matters we've taken and discussed in committee, just to have a standardised approach in terms of labels for items we take in committee, because we think that would be useful to analyse year on year to understand, so asking for that approval of that. And then the next protocol then is the business protocol, proposing one change in terms of late reports of board and committees would only be accepted if the rationale is provided and the chair or vice chair of the board or the committee accepts a late report. So that we wouldn't be accepting them as standard, they'd have to be a process and a check before we accept them.
We happy to approve those changes? Thank you very much. And I do think we have done really well in terms of adopting and following the protocol and taking matters in committee. We don't take anything in committee really unless we need to. So I think that's good going. Thank you, Hazel. Thanks to you and the team for keeping an overview of that. So 6.8 then, our minutes firstly of the 27th of March meeting. They have been out for drafting comments. Are people consent they were correct? Thank you. And then the special board on the 1st of May. Thank you very much. And then Hazel, anything on the action log, please?
Just one item. I was going to ask Chris Morrell to just give an update on action 3 on the board advisory group in terms of the partnership forum, and the other action statuses are there and just for information then.
Chris?
Yeah,